Yes.
Okay. Good morning, everyone, and thank you. Apologies for those few minutes, just waiting to people to get parked up. I'd just like to welcome everybody, including members of the public. It's really good to see you, really good. Just to also let you know that we're honoured today to have the television. Paul Boltrop is here and the media as well here today. So I hope everyone doesn't object to that. Please indicate if you do. And so that would be good, so they get a good indication of what's going on. My name is Jill Slocum and I'm the chair of the Adults and Health Scrutiny. And to my right is my vice chairman, Councillor Claire Sully. The agenda pack with papers are available on ModGov directly from the council's website from the link which was sent to members. I'm requesting that other members and officers and members of the public please turn off any videos, any microphones, your ordinary mobile phones, please. You could just do that so it doesn't disrupt the meeting, if that's all right. When I invite somebody to speak, could you clearly state who you are? The benefit of anyone who's listening to the meeting, they can identify who's speaking. Can I also remind councillors to only use the chat function solely for business matters, okay? Nothing else. It's very distracting. As the agenda is now viewed electronically, can I request that members and officers refer to page numbers from the published agenda pack to assist all present in finding the appropriate information. I'm just going to let you know that I'm not following the agenda as per se, and it'll be for the benefit, but please don't worry, it'll be for the benefit. I'm going to go to public question time. I'm going to move that to be just before item 7. That's because I want members of the public to be able to speak. Then we go into the presentation and then you get your questions answered. It's a natural flow and I think it will benefit everyone, and it respectfully gets to hear what you're saying at the time, instead of there being a gap in between. There will be a 10-minute break just after the last item before item 7. So there is a comfort break. Okay, so I hope everyone's happy with that. Item 1 is apologies for absence.
Thank you, Chair. Good morning, committee. We have received apologies for absence from Councillor Bailey. We've also received apologies from Councillor Lawrence, for whom Councillor Osborne is substituting, and apologies from Councillor Woods, for whom Councillor Rodriguez is substituting. Members of the committee, Councillor Robbins, Bruce, Stanton and Ferguson are online, Chair.
Thank you very much. As you'll see, all the members of the committee are on there, but we do have many members online as well. Okay, so thank you all for being here today. Item 2 is minutes of the previous meeting, which is page 9 to 18. Everyone is happy to approve those minutes, please. Everybody happy? Thank you very much. First and seconded. First and seconded, sorry. Thank you very much. Item 3 is declarations of interest. This is where I invite members to declare any interest, to make them aware that a list of council members' personal interests as members of the district, city and town and parish council is available for inspection on the website. But if anyone has any declarations they wish to offer up, please, now is the appropriate time. No, we don't have any. Fine. So item 4, as I said, public question time will now be in front of item 7. So we're now going to item 5, which is the work programme, pages 21 to 22. Do I have any comments for you from members about the work programme that we have before us? This will be on the 9th of October. We have shared lives, Yeovil maternity closure, in the improvement update, impacts of services, change on ambulance services, that's Yeovil to Taunton and Taunton to Yeovil, and homelessness and rough sleeper strategy. So it's quite a big agenda for the 9th of October again. Everybody happy with that? Thank you very much. Thank you. Item 6, this is the trauma-informed service support for adults facing homelessness or multiple exclusions. This is on item 6 on the agenda, pages 23 to 32. So I'd like to invite, I was going to invite Salon Antier.
Yes.
To present that, please. If you'd like to come forward, thank you. Sorry, I should have said to you, officer, please sit in the front, and yeah, thank you. Thank you very much. Just waiting for the technical bit to happen. It's always a way. Lovely. Good morning, everyone. So I'm Céline. I'm a commissioner for Somerset Council, and here with Christian. You've just got an echo on your machine. Have you got your sound off, please? Right, Yes. Good morning, everyone. We'll start again. I am Céline. I'm a senior commissioner within the Somerset Council with the responsibility of the mental health portfolio. I'm joined by Christian. You want to introduce yourself?
Yeah, I'm. Good morning, everybody. I'm head of commissioning for housing, which covers a breadth of work, including homelessness, and also working very closely with adult social care.
Okay, so I'll be going through the slides. Can you put the microphone a little bit nearer to some?
Yeah.
Thank you. Okay. So first of all, thank you very much for creating this opportunity for us to present this proposal to commission a trauma-informed service, which will be targeting adults who are homeless or high risk of becoming homeless and facing multiple exclusion and disadvantages. I will go through more details about who those people are in shortly. We have an agreed budget of £570,000 per annum for a new contract starting on the 1st of April 2026. The proposed length of the contract is for 5 years with the option to extend for another 2 years. The budget brings together adult social care and housing, and going forward as well, the contract management of the new service will be with housing and adult social care commissioners. We are proposing to go to tender on the 19th of September with all going well, a key decision taking place later on this year in December. So just a little bit of background to this proposal. First of all, we have gone through a full recommissioning exercise, including a full review of services, consultation with stakeholders, and also crucially people with lived or living experiences of those services. This as evidence that Somerset continues to have the need for a service with the right specialism and skills and to support people in this high-risk group. We know that the cost to the system attached to supporting people in crisis, and this has also informed the commissioning of this specialist support service. So the need for continued innovation and transformation to reinforce the prevention and improve outcomes for people. And obviously, as well, we are very confident that the proposed service is aligning itself to the Somerset Council plans and strategy, as well as supporting the delivery of our legal obligations. Just briefly as well, running through some of the aim and objective of this service is, first of all, to reduce the crisis intervention and the cost attached to those interventions that often don't deliver the right outcome for people. To support people to access suitable housing and timely support, to prevent escalation of needs and people admission to acute hospital, including our specialist mental health ward, to promote the safeguarding of people and positive risk management, work towards bringing down barriers
that people are facing and access universal services. And ultimately, this service will be supporting people long-term recovery and well-being and meaningful reintegration into their communities. So before I go through more of the details of those slides, I just wanted to kind of allow ourselves to think about who those people are and give you some example of people I have had the chance to meet through the consultation, and give you an idea of who we are targeting for this new service. So here I'm going to refer in the first instance to a young woman who I met, who had significant childhood trauma and suffered a lot of abuse during adulthood, and as an adult is presenting with significant mental health needs, coping strategy around substance misuse, in and out of the criminal justice system, but also with, due to the mental health needs, had attempted on several occasions to end her life, one of being to jump from a bridge, which has left her a wheelchair user, adding even more so challenges to her difficulty, and continue self-harm and unable to adjust to the expectation of adulthood, and what's, as well resulting in a lot of admission to hospitals. We have come across another young man living in Minehead, who had was in a relationship, had a good job, and one day on his way to work had a car crash, sustained a brain injury. His life unraveled and spiraled out of control following that accident and brain injury. He found himself first unable to maintain his relationship, even his family move away from him. He lost his job, unable to maintain his job, lost his home, found himself homeless, found himself in temporary accommodation because of his behavior, which was uncharacteristic of him, but of aggression due to the brain injury. He was forever evicted of any accommodation that was offered to him, and ended up living in a tent in a very challenging condition in Minehead. Those are the type of people that we are looking to support, also break the cycle of life of the cycle that they find themselves into. And I think here, by just highlighting those two examples of people and challenges that they find, I just want, among many other messages, to send a message that it's not a lifestyle choices for those people. And also that homelessness is not just a housing problem. Those people are coming, the people that we are looking to support are coming with mental health needs, substance misuse, in and out of the criminal justice system, fleeing domestic violence because of the cycle of abusive relationship. So those people are coming with significant additional needs. So next is, why are we looking at the trauma-informed approach as a key part of this model of support? What does this mean for people? And again, in consultation with people, is about, they're not going to say, Celine, oh, they're trauma-informed, that's exactly what we need. What they're going to say to me, what they have said to me, is it's a service, it's somebody who can stick with them no matter what. There is no quick fix. There are people that are going to struggle to engage, that are finding it incredibly difficult to trust others because of their experiences. There's no quick fix in their recovery journey. So what they say is working for them is having that person that is going, or that service that is going to be there long term, support them in in their progress towards recovery, support them when they have setback. A lot of the people that I've met have been in and out of prison during the time that they were supported in services. So this is what really matters to them, that notion of feeling listened to, of feeling that they're not necessarily a problem, that people are there to stick with them and support them to navigate a system that can be at times quite complicated to navigate. What does a trauma inform mean for the people supporting those services, so supporting the people? So what does it mean for the staff? It means that we are expecting that the staff team to have a robust access of support. The staff team that is going to be facing very challenging stories, witnessing significant behavior of distress, they need to have access to the right support, the right specialism to debrief. It's more than just supervision every 6 weeks. It is that debrief, that ad hoc support with management and psychologists that understand what they are witnessing. It's also about having access to support that is going to support resilience for the staff team, that's going to support creativity. It may be that an approach of support that is initially agreed with the person transpire not to work. How do we work differently? How do we have access to that real support to make things different? And I have as well, as part of the consultation, met with a member of staff who was part of an organization promoting the trauma informed, and it was interesting to hear their story, in a sense that they have been a support worker for some time in different organizations. And they were working with a person that became incredibly verbally abusive to them. And she said to me, in other organization, I would have actually I've been asked to step away, or further restriction would have been put in place, or we would have closed the case because of zero tolerance type of policy. In this organization, with the support of the psychologist, I was able to look at things differently, even to the point of even using different language. And I went back to support that person. And by changing my approach, but by also persevering in saying, you may have behaved that way with me, but I'm going to come back. I'm going to continue supporting you. The narrative for that person who was clearly testing and was used to people moving away from them, it just completely changed the way the person saw that next time that person came and support them, they started to engage. And actually by her sticking at it and changing slightly the way they were looking at supporting that person, I'd been able to continue working with them and towards their goals for recovery and further independence. Before a member of staff that it was also incredibly rewarding to be able to have pushed through and just find a way towards supporting that person positively. And so that's clearly another aspect of the trauma-informed approach, but also it is something that is how it translates in commissioning activities, and how we have also got to look at ourselves in order to support this approach being successfully implemented. So it means that we allow in this service to work with people longer term, to have a staff member having smaller caseload, using these terminologies, so they have enough time to spend with people and support them moving and towards progress at their pace. So that's something that we have to also challenge ourselves as commissioners, and how we look at services and what we expect in terms of quantitative data and quality data, and how we look at performance of those services. So another key key item about this service is the need for continued innovation, collaboration, and transformation in this space. And we would want the provider, the right provider with the expertise to continue to inform creativity and innovation for people and creating improved services. Now we are going to go straight away into having a specific request of that provider in our space, is that we do expect the successful provider to have embedded the trauma approach as part of their organization. And with that, we would want them to establish a training program to share their experience and start supporting other organizations with implementing that same approach, because that approach we know already can create, we have pockets of wonderful work across the system, but that approach will be truly meaningful when everybody's come on board with it. So this is what we want to take step towards. Yes, this is not an approach that can work in isolation. Alongside this very specific request, we are also wanting a provider that's going to be able to move with us and be part of some of the initiatives that are being created at the moment. One I'm thinking about is very recently collaboration between public health, adult social care, and housing. There's two new posts that have been creating two new social worker posts who are going to be specifically working with people who are homeless. It will make perfect sense going forward that this survey is linked up to those two new roles, including the housing team, and whereby we could look at co-location to improve specialism, efficiency, and ultimately better outcomes for people. So those are the type of initiatives we want the providers to be able to support and be with us on it. Just want to acknowledge some of the risk and also the mitigation in this space. Obviously, the budget pressure driven by increased number of people coming through services with higher needs. The risk of services not achieving the flow due to the length of people being part of those services, and also transitioning those people to new arrangements. We do have some mitigation. First, with having established very strong partnership work with existing services, we are placing at all levels an emphasis on prevention, and there's a lot of work already within housing or taking place as well with our partners of open mental health and the voluntary sector to continue that prevention work. And obviously also we recognize and we want to continue to innovate, to transform and to improve outcome as well. So a lot of collaboration work between agencies within the system to support better outcome going forward. So this is the end of this presentation. I appreciate you may have quite a few questions for me to clarify some of the details that have been presented to you, but also very much welcome your feedback about this proposal. Thank you.
Thank you very much, Celine. Thank you very much. It's, I think all of us here will recognise when you talk about life experience, it actually makes us all realise that there, for the grace of God, could go to any one of us. Mm-hmm. And I think that's something we forget. Can I just start this off by, does this also include homeless street people that are living on our homes? Do you actually engage with them? Because I know many don't want to, when we've tried to talk to them, they don't want to move. They don't, their lifestyle is everything. So how do you interact with that?
And that's exactly where, first to answer your question, absolutely this service will be reaching out to people who are rough sleeping, and it's about creating those relationships, and it takes time. It takes time because those people do not trust us.
No.
And it takes, and this is where the trauma-informed approach and the ability to work with people long-term to support a way forward and their engagement is absolutely key in this. I've just got so many examples in my head, but another young woman who was referred to one of the service that we have commissioned in the past. And it took 3 months for her to be able to respond to phone call, letters. She was completely silenced, but the service stayed with her. It stayed with her, and at the time when eventually she was able to respond, she said, "Those letters you sent me meant so much. I knew you were there. I was not ready, but I knew you were there." And it's a perseverance, a resilience that we need very much for people to start engaging.
Absolutely. None of us want to see people on the street. None of us. And sometimes we see them and we just think, you hear people shouting, "Get a job and do this and do that." Don't actually always understand. So thank you for the work that's being done. Thank you. Councillor Osborne.
Thank you, Chairman. I just wanted clarification on the sum of 570,000. It's not clear, or at least I haven't picked it up. Excuse me, I am the substitute. Is that 570,000 is that the total for the 5 years, or is it an annual total? And if it is a total for the 5 years, is it going to include the 2-year extension? And also, is that fee index linked? Because if it is annual, 570,000 today is going to be worth a lot less by the time you get to year 5, and possibly the 2 years you're looking at extension. If it is the grand total for 5 years, I'd be rather concerned about whether it's enough for the work you are looking to do. Thank you. I've got another couple of questions as well.
Go back to Celine.
Okay, so now I can confirm that the amount, the 570,000 is per annum. So
No,
it will be per year. No, it is not the full total. It is a challenging budget, and it's a very, with the ambition that we have, this is the budget that we have, has been agreed.
Okay, that's fine. Thanks for the clarification, and I'm relieved that it is per annum. I would have been seriously concerned because dividing that by 5 gives you something like a little over 100,000 a year. Remember, Somerset. I'd be very concerned that you would be struggling with that budget and you would be coming back to us for more. But that's good news. Let's park that one. One of the issues, I think, particularly when you're working with people who have been in and out of systems, is staff continuity and building up those relationships and trust. How are you going to ensure that you maintain staff continuity and stability? Because that's something that's really important to build a relationship. And also in terms of time, because some people may take time, and also patience as well to make those breakthroughs. So how are you going to ensure that?
Thank you. That's an incredibly good question. And this is also where this model of trauma-informed really has a place. When I was talking about the robust structure that is required for the staff team to operate within, we have got evidence that model of support really helps staff retention and support them to feel to be well in their work. And this is very much something that is absolutely key to this model, because yes, we will be wanting people, it's a micro team around the person. They can't see different people at all time. So we will want people to create continuity of support for a long-term period. And it may be that we know that support can start very slowly when the relationship is being built, and it could take a year to get someone to a place where people really engage with that person. It could be that initially people are actually really happy to engage, and so there's a lot of support that goes in right from the beginning, and then they disengage, and so there's a cycle. There's a cycle around engagement that we've got to be mindful of. Hence the long term. We also know how meaningful for some people who have been in services for some time, it may be that it's just a phone call a month after a while, or a visit a month. but that visit, that phone call is incredibly powerful to keep people well. So it's all of this and that continuity of support that is absolutely key to this service.
Thank you for that. That's very helpful, and that it does seem as though the service is going to centre around the individual and what the individual actually wants, rather than what might be in the interest of the service. Sometimes those two don't always go together, so I'm really pleased to see that emphasis on the individual and getting that individual and giving them the time and the patience to actually overcome the obstacles they face. My final question on this one is, you've talked about co-locating teams. Where do you see these teams co-locating to, bearing in mind our next agenda item, and what are the timescales, and what sort of timescales do you have in mind for this? Thanks.
This is the ambition. I can't tell. It relies on so many variables. The timescales will be within the length of this contract. I don't know, Christian, if you want to comment, but I guess if there's already a co-location, to my understanding, with the rough sleeping team and the social workers, two new social workers, so that looking at the logistics or having with services integrating as part of the first team. This is a real big ambition of mine, because I really can see that really creating further specialism and efficiency as well. But yeah, I guess I don't know if Christian you want to come in and support.
Okay, thank you, Celine. Yes, in answer to your question, Councillor Osborne, with the integration of adult social care and housing, this is a quite exciting time in terms of integrating a lot of our contracts, and this is one example that Celine gave. And what we're finding is to touch on a point earlier on, there are many services, including our health colleagues, who are at touch and interface with many of the people that we touch on a daily basis. And because you're at the sharp end, dealing with the problem that's there at the time, like A&E, or in homelessness, or in a social care setting, they can only deal with that point at that particular moment in time. What we're trying to do with this trauma-informed contract is ensuring through joint commissioning the awareness across teams and across health and others, so that you mentioned continuity earlier on, that people know who to refer to, because the trauma-informed team will be able to then spend that time, as Celine said, with those individuals, but also they will be able to help us with induction of new staff, so that all staff right across the services have some form of induction around trauma-informed. So it becomes an everyday part of the cycle. We all, when we start work, we learn about health and safety and all those key things, but a trauma-informed process is very important to that. And what Celine was saying then around co-location, absolutely, as I'm sure Paul will agree, part of the key to this moving forward is that we look at a lot of our contracts to move partners working together in hubs together. Won't always be appropriate in some instances, because it depends on the service and the customers that come through the door. Because where you've got children, for example, you might not want certain types of clients sort of interfacing with that. We've got to be very mindful of that. But I think what that will also do as well, by bringing people together, it should be a one-stop shop, people getting many of the services that they need, but also those services talking with each other and keeping themselves informed of developments and so forth. It's almost like going back to the districts kind of thing, isn't it? But bringing everybody together. So hopefully that helps. But over the life of the contracts, we'll be talking 5 years for many of the contracts we're doing in housing. We'll be working very closely with our adult social care colleagues, our health colleagues and others to think about how we can move those services out into the community.
Thank you.
Thank you. Could you turn your microphone, Celine? Sorry. Yeah, thank you very much. Can I go now to Councillor Trimnell?
Thank you, Chair, and thank you very much for the presentation. Now, obviously, we had a briefing the other day, and I do apologise for the noisy place that I was in, but it was really interesting, and this is a really important service. I just had a couple of questions. Do you have an expectation for the number of people that you're going to be dealing with? I mean, obviously, you don't know year on year, it could change, but, you know, have you sort of worked out those parameters? I wondered if you could break down the funding. It said that the funding came from the adult social care budget and housing. So is that proportionate? And finally, I suppose I wanted to know about, is this a new scheme, or have we been running something separately between those two departments before, and we're bringing something together as a joint commissioning exercise, as in you are now working jointly anyway under the adult social care umbrella? And is there grant funding? Is there more money that you may be able to get should the need for this grow?
Just remind me of your first question, please.
So the number of people, I know, I'm sorry, I blurted out too much in one go.
That's fine. We are looking for this service, and based on all the services and what we know of those other services, we are looking at the capacity of that service being 130 people. Yeah, because we're talking about that high end of need. And a lot of work is taking place around prevention. But with the budget that we have, we also got to be realistic of how many people can be supported through those services. But at the moment, based on what we know, we'll be looking at this kind of numbers.
I do apologise. I'm now coming in within the questions, but I mean, you would expect people to come onto the system. You would hope that they will reduce their need for that. But are you sort of looking at people generally rolling in and out within a period of 12 months, or will you be accumulating people as you go on?
Some people will be able to move on safely to other services, because I guess this is also the key point about this service. This service won't be working in isolation. It'll be the key link with other services, part of the community, can also offer a lot of support. So the idea is that when people can eventually move on to other services, they'll be transferred safely to other services and so on. But yeah, we know that as a starting point, this is a number that we're looking to support in that space. In terms of budget, to break it down, we've got, from an adult social care point of view, a budget of £420,000 per annum, and with the housing coming in to support us, to support this project with an additional £150,000 per annum. We also know that a lot of work continuing to take place from certainly the housing side. You may want to chip in there, Christian, to potentially be able to increase this budget going forward. And it's something that we are, as part of the contract, also mindful of making sure that this is a possibility in the next few years.
Yes, thank you, Councillor Tuna. We receive homelessness prevention grant from the Department of Housing, local government, and as part of our contract reviews at the moment, we have quite a lot of duplication, which naturally would have occurred as the districts came together because of their original sovereignties. So we're looking at how we can bring those contracts under one in commissioning moving forward. And also our adult colleagues and children's colleagues, Thrive 16 Plus is a great example of a contract for children, how we can do some joint work and efforts around supporting our clients through contracts that already exist, existing frameworks. So some of the savings we can then bring down or draw down from that homelessness prevention grant, we like to put into other initiatives such as this, so where we can expand that and maybe take some of the pressures of adult social care in their budgets, or look to expand the service further because we've identified that need. But as Celine said, we need some flex in these contracts so that we can do that kind of thing.
Thank you very much.
Thank you. No, I was just going to say, so effectively, it is something that housing had been working on in their district areas, and obviously adults were. So it really is a piece of work that's now being brought together. And yeah, this is very exciting. Thank you.
Teamwork is essential, isn't it? Yeah. Councillor Rodriguez.
Thank you, Chair. Thank you for the presentation, and I felt the explanation of the individual kind of case work experiences was really useful to understand the type of work that you deal with, which is really useful. Thank you. 3 questions, Chair, if I may. My first one is around one of the aims and objectives that you showed in your presentation. The first one was reducing crisis intervention and the cost attached. to such interventions. As that is one of the aims, I'm just wondering, have you done any modelling into what the reduction in that cost may be, and what kind of savings, or should I use that word? I'm not too sure. And I know it's not all about money, but as that's one of the aims, I'm just wondering if you've done that piece of work and what that number may be.
What we know, we had a study conducted about what it costs to support people in crisis, during a crisis intervention, with a number of professionals that have to get involved and support that crisis. So we have those costing, which are far more than this, and it was conducted over a period of 4 years, supporting six individuals that were continuously in crisis intervention. And we have those costing, which is far more than this contract is in terms of its budget. So in that sense, we know what can be achieved in supporting people well, at the right time, in a right place. We understand what it costs to support people in crisis intervention, and we would like this to be transferred the ambition would be to transfer it as a saving by supporting people before their needs escalate and are in crisis.
Thank you, and thanks for the response. Perhaps really useful to understand what that figure would be, perhaps at a future meeting or a briefing paper or something like that, just to understand that bit further, but appreciate that. That's really good news. The second question was around working in partnership with the VCSE. I only wonder, what does that mean for organisations that are already doing quite a lot of work out there? And I only think of Bridgewater, not far from where we are, Westfield Church in Bridgewater, who do the drop-in at the church, washing facilities, food facilities, working with housing, ARC and other partners. I'm only wondering, is that going to be impacted in any way? Are they going to see a different kind of way of delivering what they're delivering? I'm just wondering, those partners that are doing the work already, how will they be impacted, if anything?
Councillor Rodriguez, I can answer that question, having been close originally to the contract from when we were Sedgemoor. So we're working with a lot of those providers at the moment to realise what the future might look like for them, because there's lots of ideas and commitment that they have around what they'd like to deliver. And with this new horizon now, with adult social care and housing and children's working closely together, we've got some new ideas that we're bringing forward. And we touched very much earlier on sort of the hub model about bringing people together. There's also a lot of reliance that have been put on some of the sector for things which they feel uncomfortable with as well about. So we're trying to look at how we can shift that emphasis. But in terms of the impact on those organisations, no, that would have the opposite. And also, just to pick up on a point that Celine raised just now, we have what we call also professional blind spots, whereby sometimes, because as I said, we're at the sharp end of dealing with things, we all have our commitments and our different attributes that we're trying to deliver. Sometimes some people don't actually go through the system properly. So actually, because they then get spat out somewhere else, the increase in cost happens somewhere else. So in the model that Celine was talking about, we've got an excellent model in terms of working out the costings, but also we think if we can remove some of those professional blind spots, and that's what part of this contract is about, it's about raising awareness, trauma informed, then I think actually we could reduce costs even more than the model is going to is demonstrating.
If I may add as well some further information as part of the recommissioning and the consultation I have conducted with stakeholders, there was a real sense of value of that additional service to the short-term intervention and how that could complement the services they were doing, but sometimes they didn't feel they had the right skill, the right setup to support people that are presenting with more complex needs. And that service is seen as well as complementing what they do. So it's not, in that sense, it's a positive addition.
Great, thank you, Chair. And my third and final question, Chair, is just around, you worked talk about working with different partners, great. I'm only wondering, because there is a very, very small number of homeless that cause anxiety or challenges in town centres in particularly, very small number. And I'm just wondering, you mentioned various partners you work with. I didn't hear you mention local police or maybe town councils as well, because we're asking town councils to do a lot more nowadays. I'm just wondering, is that part of the commissioning as well, where you're looking at working closer with town councils to deliver some of the work or work with partners a bit more strongly?
There certainly will be an expectation for this provider to link up with all the agencies that are part of supporting a solution for some of the people. So yeah, that's very much part of and that's why I was also trying to convey there are additional conversation and that are being part of the system that are taking place to support this. It is a collective responsibility. So this service will be there to navigate an answer, but it does rely as well on other agency and part of the system to come together and support an answer. So this service cannot work in isolation, and there will be an expectation that other organisations come to the table as well.
Thank you.
Thank you. Councillor Govia, please.
Thank you, Chair. Councillor Govia, councillor from Wellington. Thank you for the presentation. I found it really helpful, and this is I think a really good example of where the position we find ourselves in with now a unitary authority allows us to work more closely together. And I think that that's something I know people have different opinions on whether we should have a unitary authority or not, but I think this is probably a very good example. And I also recognise that you're dealing with a very difficult cohort of people, very often not through their own fault. They're people who've been failed by either their family, society, or as you in your example you gave, someone who's just was going along, their life was quite good, and then all of a sudden an accident created a spiral. The one question, and I know this is probably something that's a little bit further down the road. I mean, the key to cutting off the number of people in this category is obviously prevention, and that's highlighted as one of your things. And I wonder if there's a plan to sort of when you get these people on board and engage with them around the issues that brought them to where they are now, if there will be informed discussion and sort of lived experience passed back to the prevention side of it, because to be honest with you, the prevention has to take place a lot further upstream to cut off these numbers in the future. We don't want to your service is vital at the moment, and there will always be some form of service, because there will always be people who slip through the net, unfortunately. But the more we can stop people through prevention earlier in the system, the less serious people will come to you, and the less serious their ACEs will be, or whatever else whatever their face. So I think I wonder if that's something that you've looked at. Thank you.
Absolutely, and for those very reasons that we're now in a situation where we let people needs escalate to the point where it becomes incredibly difficult then to reverse the cycle of behaviours they are into. So there's a lot of work taking place with our Open Mental Health Alliance, Thrive, our community agents, who have a vital role there as well to support people at a time where their needs are, much easier to use to support. So there's a lot of work, and even with housing colleagues, I've done a lot of work, and there's a lot of project taking place. I'm part of a new project taking place, which would be a collaboration between public health, housing, and ourselves in adult social care to look at detox program for people. So again, to support people to disengage from substance abuse at an early stage, which doesn't lead them to other behavior and consequences we know. So there's a lot of work taking place right now through to support that prevention agenda. Yeah.
Thank you.
Councillor Gilbert can add to that as well. When the council restructured and housing went into with adult social care integrated directorate, We also created, instead of having just sharp end of homelessness around its statutory duties, we also created the commissioning team, which is my own team, which will have the space and time to think about the various activities that we need to commission, but also the prevention team as well. And my colleagues Sam, Wendy and Delira. And the idea of that is to try and, as Celine said, try and prevent people from coming through into homelessness in the first place. So they're doing a lot of activity around sort of working with ourselves to look at services which could upstream, if you like, to catch people early, particularly through the VCFSE, because the community is so important to engage initially, right at the beginning. And instead of the stigma of the community here and then homelessness or potentially homeless people here, about the community working with people who could become homeless, to help them to provide and empower them themselves to be independent.
Thank you. Thank you. Councillor Hobbs, please.
Thank you very much for the presentation. My question leads on to the thing that Councillor Rodriguez said about liaising with the police. We see few police and their support staff on the street, but you see quite a lot of homelessness, which also can be picked up by our enforcement team. There was a chap in Wales a few months ago, obviously quite badly mentally damaged, who managed to access some help, mainly because he thumped me. So I actually reported it to get him the mental health support he needed. And I spoke to the police soon after. So I don't want the chap prosecuted. I want him to get into this system and see he receives the help. But as I spoke to the police officer later, he said, yeah, you go into the system, we managed to get him on a short-term sanction. He'll then go back to taking his medication because they come off the medication, they think they feel okay. And you see the repeat cycle behaviour. Councillor Agabani, who's sat over there, may know who this chap is, the one who manifests himself as a leader of religious faith, who will appear around Wells periodically, having gone into the system, presumably received some help, and then the cycle behaviour is repeated. How do we help stop cycles of behaviour repeating when people who clearly are desperately in need of help in that instance? And my other question would be totally different. We see and can quantify and count rough sleepers in streets, and we know the hotspots in tented areas around places like Wells and Shetland. Do we have any figures for people who are sofa surfing? Think of a large rural area where we see them dotted around the towns. They're easy, but lots of us represent large rural division, people like me and Councillor Sally. Do we have any figures on people who are sofa surfing at friends and things like that, who are also stressed, like, where am I going to be sleeping? Am I going to be cheesing my friends off and outstaying my welcome? Thank you.
I'll try to answer the first question. I guess I think it goes back to the observation I've made during my presentation. There's no quick fix, and it is about to break a cycle of behavior of people that find themselves in this situation. It is about perseverance, but I can't reinforce enough the collective responsibility. That service that we are proposing to have absolutely got value and pace and support people to have a person alongside to navigate the system, but to support them to trust that intervention. So intervention from the police, intervention from maybe the psychiatric ward, the support that they may need from, and to be able to engage. And that service, that almost that holding hand by somebody that they can trust, that has taken time to establish a relationship with them, can create the solution.
Thank you.
It is about that perseverance and resilience. There is also, we need to acknowledge that we are not going to be able to support everybody.
Thank you. Councillor Wakefield. Yeah.
Thank you. I just wanted to add about that this is, again, as Councillor Gogo has said, this is one of the opportunities of unitary, but we have, when we speak to the Somerset Foundation Trust, when we have board meetings, we're talking about people being kicked from one service to the other and how we can stop that and break the cycle, because that is really crucial, because it doesn't do anybody any good to do that. And it's one service saying, oh, we've signed them off, they're out of us, they're in the next one. And that exactly what you said, Councillor Hobbs, is something we're really trying to do something about that. And it's this working together, which we're able to do now. We have the foundation of trust, which covers the area that we're talking about in Somerset. And we talk about it in our meetings, and we talk about strategies for dealing with it. So I'm really hopeful that with things like that Delaney has been telling us about, those sort of services. The other thing I would mention is, and people may not know this, the NHS are doing outreach with GPs and nurses and going to visit people who are rough sleeping. And what the feedback they're getting is those same people come and see us, and we trust them because they come and see us. So that sort of thing works. It's being able to rely on and start to trust people again, which can start to break through some of these cycles. And it's awful that we have entrenched in our society people who are in this situation and unable to get out. And just assure you that the council and the health services are doing their best to make a difference to this, and our strategy for homelessness and rough sleeping, which we've also recently done in the last year, that is now coming to the action plan stage, of which this is part. So I just wanted to reassure you about that.
Thank you very much, because obviously Councillor Wakefield is our portfolio holder. So the information is very, very valuable. So thank you very much. Thank you. Christian, do you wish to come back? You can have 1 second, Christian.
That's all right, you know me. Thank you, Councillor Slocum. Coming back to Councillor Hobbs' question, the second one we didn't answer, around safer surfing. I can ask my colleagues about the numbers on those to see if we do have them before scrutiny. We can provide them to you. Just to pick up on what Councillor Wakefield was saying as well, back in my previous role, which we know when I was doing disabled adaptation service, one of the areas we had was working with the rapid response teams and NHS colleagues and social care teams about trying to prevent people coming back through the cycle, because the rapid response team would go and see somebody who had a fall, and then they would people. So what we did, we worked with them to provide grab rails and so forth, and then using their NHS number, we were able to trap people through the cycle and prevent them from going back through again for our adult social care colleagues. So I think, again, we started to have that conversation around how with our homelessness clients, we can use the same model to start tracing people, as Councillor Wakefield said, try and stop the cycle.
Thank you for that. I always think of you, Christian, as adaptations. I always came to you in the old days, and then I found that you were still doing similar work, so that was really great. So thank you. I have 2 online, the last 2 speakers online, but we have Councillor Sully next, and then I'm going to do the last 2 speakers, if I may, because time is running short and we need to keep focused on our next agenda item.
Thank you for an excellent presentation and giving us the lived-in experience, which was very powerfully conveyed. Quick question, really. It says, you said there was an observed trend of increasing number of people coming through the services of higher needs. Amongst your cohort, I'm thinking about women who are facing trauma through domestic violence. The police have said we've got a national epidemic. It's not really discussed that much, but I think it's very alarming that we have to have this at the moment, and not doesn't look like it's going away. So I just Councillor Hobbs mentioned the sofa serving. I'm just thinking about that cohort and that particular challenge. And are you seeing that and experience that women are particularly coming forward, and are they part of that observed trend of increasing numbers of people with higher needs?
I wouldn't be able to comment per se on the increasing numbers, but I am aware of this cohort of people, and also some of the work that are taking place by the Nelson Trust in here in this space. There's a lot of support here, but equally we have some gaps in services when it comes to, and again, something that we are looking at with our housing colleagues in terms of where people live at accommodation and not female only type of space. There is more work that we need to do around this. Yes, absolutely.
That might be something that we bring on a separate issue, I think, rather than yourselves today, but something we can bring back up as we always do. Okay, I'm going to 30 seconds from Councillor Triminal, and then I'm going online.
So 30 seconds. So, many of you may have seen the video yesterday of a young man homeless in Birmingham, his leg covered in sores, crying. It was absolutely horrendous. And I just feel, as a scrutiny committee, we're supposed to make recommendations. And I think we have our homelessness and rough sleeper strategy coming forward. I think it would be really good to have, as we approach winter, some kind of briefing for members about what we should do if we hear of stories, situations in our areas. What can we do to help this winter? Because it's going to come to the fore. It always does in the winter more than the summer. And it just occurred to me that, you know, not everybody knows what to do. So it would be really good to have something like that. Thank you.
I think very well worth 30 seconds. Thank you very much. So we'll put that recommendation forward if we may, Jamie. Will you take a vote on that? Is everybody happy to take a vote on that, please?
Yeah.
Everybody in agreement? Thank you very much. Thank you, Councillor General. As always, worth 30 seconds. I'm going to go with the last two speakers online. Councillor Christine Lawrence first, please. Councillor Lawrence, are you in there online? She does have line problem. I know she has connection problem. Councillor Trimnell? Councillor Lawrence? Got you on my brain. Okay. Can we go to Councillor Bruce, please?
Morning, thank you, Chair. Can you hear me okay?
Thank you.
Can you hear me all right, yeah?
Yes, perfect.
Okay, great, thank you. Apologies in advance, this is a bit of background noise and I can't put my camera on for bandwidth issues, so I'm sorry I can't be with you today in person. Thank you, first of all, for the presentation and for giving Scrutiny the opportunity to actually input into this in advance, at quite an advanced stage. So that's quite good to see. A couple of points I wanted to make. One of them is to ask whether this is quite an innovative approach across the country. Are there other councils who are taking this trauma-informed approach and integrating the integration between services? Are there other councils that have been doing this already for a while, or is it something quite new? I'm really interested to know if there's any kind of knowledge sharing that we can take from other councils that are already working this way. And the other point I wanted to make was you talked about sticking with people who maybe are not always feel that they're able to access services, making sure that there is that continuity. I would just like to emphasize the importance of training for staff in all services, not just those services that are dedicated to dealing with people in these situations, because there have been cases where somebody's tried to access the service and maybe has issues with being aggressive or anger management. And there is obviously that balance of protecting staff and not having to deal with people being aggressive or showing anger towards them, but also understanding that some of that anger and aggression can come from the trauma that they've experienced or are experiencing. So they need to be dealt with in a particular way, maybe differently to somebody else. And so people who are the first point of contact, it's really important that they also have that training as well. So I'm sure you mentioned training in the presentation. I'm sure that will be incorporated, but I just wanted to highlight that point. Thank you.
Councillor Bruce, do you wish to respond at all to that?
Yes, I can. I guess obviously there has been obviously some research about what's happening elsewhere. We know the trauma informed, for instance, is incredibly well adopted in Scotland. We have on more closer to us, we have worked in liaison with Manchester, who has adopted this model and doing, that model has definitely had an impact on the cohort of people we are talking about. So we've taken it even in the introduction of 2 new social workers in this space. That is also something that's been influenced by the experience that Manchester Council has had as well in this. So this is something that we've taken from them as well. Yeah.
Just to add to that, I mean, we all know that there's a sad situation with Susie Lampley many years ago, and many colleagues have the Susie Lampley training, which is really important for in solo visits, etc. And I think close to Celine in my heart is with this contract is that I think everybody should be trained in understanding trauma, because we see many people who come to reception, and we have security there, of course, but obviously we're trying to deal with the physical element of it first of all, but it's also being able to understand that person's situation so they can be informed and put into the right situation.
Yes, thank you. That's very self-evident today. Okay, I'm just going to try again. Councillor Lawrence, are you there? No, I don't think so. Okay. Right, then I'd like to sum up now, please, if that's okay. I think we've got the recommendation for the trauma approach. I think that will needs to go for all member briefing. I think we'll put that forward.
Oh, sorry.
It's all right, Councillor Lawrence, we tried to get you, but if you'd like to ask your question, thank you. Councillor Lawrence, do you have a question?
Oh, yes, I am. I'm very interested to know the effect of the weather that was had on so many older people this summer, because we haven't had hot summers like this for a long time, and I'm guessing that there's been a lot of pressure that we haven't had, because a lot of people don't necessarily drink enough when it's as hot as it is and actually need extra help at certain times in the day. And I was just wondering whether or not you have noticed sincere much more pressure in caring for people.
Yeah, no, I know. Thank you ever so much, Councillor Lawrence. It's something I think that we always discuss, and I think when they're going around to the homeless people, I think that's something they're checking out on. Thank you very much for that question. Thank you. Okay, now moving to the summing up, I'd just like to say that we will put the recommendation forward. I think would also, you're going to go through the procurement process, and I think that starts from 19th of September to the end of December the 16th, December the 10th, sorry. We would like to know how that's going on. I think if you can come back within 6 months to us, maybe a bit longer. I think we're going to have this trauma, we're going to have this briefing, we're going to put the recommendation forward. But what I'd like to know is, we'd like to come back with how things are going. Financially, how your budget is going, how that's meeting the needs, and if there's any differences. And if you want to talk to us about anything else, I think it would be really relevant. I think we need to keep talking to you. It's a big issue for everyone in every town, and I think we need to embrace and link together on knowing what to do. And also, as Councillor Trimlin said, for us to know as well how to deal with it as councillors. I think we're on the street, we're on the roads, and we see many people, and it's knowing where to find that help. It's knowing what to do. I think that would be very, very good. So I think if we work as teamwork again, I think that'd be exceptional. So thank you both for today. Very, very informative and really very, very good. Thank you. Really nice to speak to you both. Thank you. Thank you. Okay, at the moment now we're just going to close the meeting for 10 minutes. We are running, I will tell you, 8 minutes over. So we're going to stop for 10 minutes and then we're going to go straight into public question time. Thank you. Please don't worry, you're my friends. And we really, really thank you for your time coming today. Your opinion is very, very valid to us. We want to hear you and we appreciate it. You're all given 3 minutes each to speak. I will be strict on the timing because I don't want to allow anyone else not to have the correct time. So we are restricted here today. So I'll just wait for Jamie to take his seat and then we will start the process, okay? But please don't worry about anything. We're a nice bunch, okay? Okay, so the first lady to speak is Melanie Warburton. Okay, and if you'd like to start now, Melanie. Thank you.
My name is Mel. Thank you for the opportunity to speak today. I'm extremely concerned that the closure of community hospital beds is being actioned prior to the availability of suitable community hubs or necessary services to enable patients to transition from hospital to home or relevant care providers. This plan must be delivered with due diligence, ensuring safeguarding and providing appropriate support. Not having the infrastructure in place before these changes occur is an unnecessary burden on our already overwhelmed healthcare system in Somerset. With the government enforced extra housing building, surely community hubs could be included under the 106 agreement. Our personal experiences are that A&E departments are overstretched due to demand and their inability to source hospital beds as required, some of which is due to bed blocking. Some GPs are adding pressure by sending patients to hospital when they could easily be treated within the surgery. Ambulances are backed up at A&E as A&E is overcrowded. Sure, that this leaves them unable to attend further call-outs as they can't hand over their patients to the hospital. Surely, to create better flow and provide responsible patient care, it's imperative that smaller community hospitals are utilised by playing a pivotal role in transitioning those no longer needing the level of essential care provided within main hospitals, but who not yet able to live independently or be supported in a care facility. Isn't that what the 10-year plan's about? Whilst agreeing that people are more likely to recover at home more effectively, I feel that this needs to be done in a safe and relevant manner with the right treatment, right place, right time, no wrong door approach. Our daughter had an awful car accident in June 21. She had an 8-day stay in Southmead, then moved to Yeovil Hospital, then on to West Mendip, and then home once she'd been rehabilitated by the physio departments. This showed how the health service can do it successfully without burdening itself. Utilising each hospital's strengths in a patient's treatment and recovery seems the best strategy to me. Even as a test project, history has shown us that much needed facilities are taken away, they are hardly ever reinstated, such as the maternity unit in Shepton and the stroke unit there. We know that our two main hospitals are chock-a-block and the knock-on effect this has. Until social care and health services are looked at as a collective, we will continue to have fractured services that are more costly to provide. We are all aware of the need for reinvigorating and restructuring the NHS and adult social care services, but an attempted quick fix, such as closing community hospital beds, will exacerbate the problem, not solve it.
Well, that's
Is my timing all right?
excellent timing.
Brilliant.
Excellent. And I do hope your daughter is well now. I really hope that she's rehabilitated and doing very, very well. So thank you very much. Thank you. Thank you. Excellent timing. I hope everyone else is going to be just as good. Now we have Councillor Diego Rodriguez to speak on behalf of Ashley Fox, the MP.
Thank you, Chair. So this is written on behalf of Sir Ashley Fox, MP for Bridgewater and Burnham. Thank you for looking into the complex issue of healthcare in Bridgewater and Burnham-on-Sea. This includes a proposed reduction in beds, merging of medical practices, and a movement of services from one location to another. For many of us, this is causing a great deal of uncertainty from a service where surety is much welcomed. On proposed bed reductions, we know that the NHS Trust is looking at reducing the number of beds in both towns. The problem is that beyond this worrying headline, we have very little accompanying detail. Residents are quite right to feel nervous, so we need to know what is happening to those patients that would be using those bed spaces. Both sites are full, and I suspect that sick people will not suddenly get better. So what is the long-term plan for their care? Bridgewater is a growing town, and I would have thought that bed spaces would have been increasing to meet that growing population rather than reducing. And what will we put in the now freed up space? Will we see an increase in services, and if so, what? It would be great if, for example, to see an X-ray machine or chemotherapy treatment in Burnham-on-Sea, but we have no detail. On the changes in services, as well as the above, it's currently proposed to move the minor injury unit from the community hospital in Burnham to the GP practice across the way. When combined with a halving of hospital beds, it is easy to understand why local residents are concerned about a hollowing out of the hospital as a smokescreen for future closure. So what assurances can the NHS Somerset give to residents that this isn't a prelude to closure? On the merging of practices, Symphony Healthcare Services have informed me of the merger that they're proposing of Burnham and Barrow Medical Centre and Highbridge Medical Centre. I want to be clear, I'm not yet convinced that this proposal will deliver the improvements our community needs, and I remain sceptical about what this and other recent plans really mean for the future of healthcare in the Burnham area. We are often told that efficiency and resilience are the goals, only to find later that it was a code for cutbacks or downgrades. The assurance that all sites will remain open is welcome, but we've had similar commitments before, only to see services slowly hollowed out. The Trust has said that they will keep the free practices at their current locations, but how long does this promise last, and does it also mean that no site will see a drop in staffing? This issue is more than just preserving the buildings. These three issues combined create a worrying picture for local residents. We need NHS Somerset to come forward with a long-term plan as to how they intend to improve healthcare in the Bridgewater constituency. And at the moment, we have far too little detail. He wishes us well in our deliberations.
Excellent timing. Thank you, Councillor Diego Rodriguez. Now I'd like to invite Councillor Sharon Perry to speak, please. 3 minutes. You're being timed.
Hi, good morning, everybody. My name is Sharon Perry, and I'm a councillor on the Burnham-on-Sea and Highbridge Town Council. I'm here today to speak about the reports that Somerset NHS Foundation Trust is reducing bed spaces at some of its community hospitals. The Burnham-on-Sea War Memorial Hospital is a much loved and cherished asset in Burnham-on-Sea. Staff, our residents and the Town Council are deeply concerned at the possibility that beds will be closed at the hospital. The plans of Somerset NHS Foundation Trust and their potential impact on our hospital was discussed at the Town Council meeting on the 11th of August. We agreed the following question be sent to this committee. We note with concern that Somerset NHS Trust is considering closing local community beds across its community hospitals. What plans does it have for beds and services at Burnham-on-Sea Memorial Hospital? We request that Burnham-on-Sea and Highbridge Town Council and its residents are consulted about any proposed changes to the provision of healthcare services at the hospital at the earliest opportunity. In the report to this committee under item 7, I see that discussions have begun with the Friends of Burnham Hospital and other colleagues at the hospital. When will a wider consultation with Burnham-on-Sea residents, the Town Council and other stakeholders take place so that we can have our say on the future of our hospital? We need clarity, we need detail, and we need meaningful engagement. Thank you.
Thank you very much. Another excellent time. Thank you. Thank you. Can I invite Kerry Joyce to speak, please?
Hi, Kerry Joyce, Chair of the Friends of Burnham Hospital. We recognise that change must take place and it's essential to follow best medical practices. Our hospital, founded by public subscription, has seen significant changes over 100 years. To remain relevant, it must continue to change and adapt. Many changes have been funded by the Friends. We've donated well over £2 million to the hospital. We also own the Peter Holmes Annex and land which is leased to the NHS. When considering the paper, we considered factors that differentiate us from other parts of the county. Burnham is a favoured retirement town with a large percentage of elderly. As a seaside town, the local population doubles during the holiday season. Burnham, although it's relatively close to other hospitals, public transport is very poor and unreliable, and none of these locations are easy to get to unless you have access to a car. Many of our residents are reliant on public transport. There is also a significant shortage of residential care homes in the local area. This context is important and underpins our perspective of any changes. Our significant concern is that prior to any changes, appropriate local facilities must be in place to support patients who need inpatient beds before any are closed. And somewhere in the county is not acceptable. Of concern is that an organised consultation process must take place, ensuring residents are invited and heard. We have yet to visualise how this might happen. Proposals to establish neighbourhood care centres, depending on the services, would likely bring significant benefits to residents of Burnham and district. It is our understanding that around half of, or all of the existing beds would need to be lost to make way for new services. Medical opinion suggests many occupants of those beds would be better served in alternative accommodation. Unfortunately, those alternatives are not currently available. Local care homes have long waiting lists. For many years, the in-beds were used by locals, sometimes for end-of-life care, and it was easy for friends and relatives to be there to be part of the support. We are told that many inpatients in Burnham are not from the local areas. Why don't locals have first call on these beds? Is it because there is a shortage of local beds elsewhere in the county caused by temporary bed closures to provide positive changes at other community hospitals? Many of our older residents live alone, with family often in distant parts. What does that mean for care home? We are aware of at least 3 elderly people who have been taken home without a care plan. In conclusion, we recognise that change must take place and it is essential to follow the best medical practice, but without substantial planning, consultation and resources, it will fail. Thank you.
I've been very good to you. I've allowed you to go over 3 minutes.
I had some of their time, didn't I?
Yes, yes, I think that's a very good point. Thank you. Yes, I think that's a good point. Okay, now I'd like to invite Miss Lewis Agabani. Apologies if I've pronounced that wrong, sir.
Okay. Thank you very much. My name is Louis Agabani. I'm the Mayor of Wells. I'm here representing everybody in Wells. So about 30 years ago, in the last 30 years, Wells has lost its cottage hospital. We've lost our police station, and I think it was about 5 years ago now, we lost our St Andrews ward, which was a mental health ward that was also in Wells. So all services are really gone. When the cottage hospital was closed, we were promised that the beds would be kept local. And about 5 years after it was closed, West Mendip Hospital was opened, and now the beds are being halved. So those promises are being broken. My question is actually to you guys, not to the trust. Given that we are in mid-trial, or about to enter a trial, there will be a cost. And what are you guys prepared for this cost? What is it going to cost us, taxpayers? If this trial is successful and becomes permanent, what are the implications to a council that is struggling with finances? Thank you.
Another excellent time. Thank you very much. Thank you. Very precise. Thank you. Now we have Taz Hashim, and next two speakers is Sarah Baker, who unfortunately cannot be here, but our manager, Democratic Services, is going to read them out for us. Thank you.
Thank you, Chair. Hi, my name is Taz Hashim, and I am a resident of Somerset, and I'm deeply concerned about bed closures at local community hospitals. Please could you answer the following questions and reply as soon as possible. About the decision process, what evidence or data was used to decide on closing beds in community hospitals? Who was involved in making this decision, and were any independent reviews conducted? Why was there no public consultation before these decisions were made? What alternatives to bed closures were considered, and why were they rejected? About impact on patients and staff. How will these changes affect patient care, especially for vulnerable groups like the elderly or those with complex needs? What provisions are in place for patients who can no longer access local hospital beds? How will you ensure continuity of care for patients who are discharged earlier or cared for at home? What support will be provided to staff affected by these changes? About community care and resources. How many additional carers, district nurses or community health staff will be recruited to support care at home? What investment is being made in community health services to ensure patients receive safe and effective care outside hospital? How will you monitor and report on the outcomes for patients moved from hospital to home care? About transparency and accountability. Will you commit to a full public consultation before any further changes are made? How will you keep the community informed about future plans and decisions? What mechanisms are in place for the public to hold the NHS authority accountable for those decisions? About the future. What is your long-term vision for community hospitals and local healthcare in Somerset? How will you ensure the sustainability of local health services given the rising demand and ageing population? Kind regards, T. Hashim.
Thank you for that. Your timing was good. And now Sarah Baker.
Thank you, Chair. What we need to see is some IUCB commissioned pathways. What does a pathway look like? All other health bodies have clear commissioned pathways for medications and access to health support and medication. Why is Somerset FT calling the orders? For too long, our health commissioners have been AWOL. The only focus of all health public engagement is focused on elderly care, despite public attending to share alarming concerns. Do we have paediatric waking nights nurses for those who need 24-hour nursing care? This was never commissioned. Does MPH still only provide a paediatric bed in a bay of 6 for NH admissions? When stepped up a service, how is paediatric NH inpatient support provided? How many residents with each of the long-term health conditions do we have? How does this compare with the JSNA? How do consultants review the decisions of registrars who oversee training of staff at MPH? For many of us who receive health support, we are left to see and experience working environments that should not have happened. This also correlates with changeover day for new placements. Each time MPH have closed services, they did without any form of public engagement or discussion at the JHWB. There is a lot that has been left without suitable holding to account for years. We need to start seeing transparency.
Good timing again. Excellent. Councillor Sully has some questions, but I'd like you to, can you wait until we're in the body of the meeting, and then I think that would be much better. Then, ladies and gentlemen, we have 4 esteemed people here from NHS or different parts of it. Now, they're going to do a presentation, and I would absolutely ask you, please do not make any comments or anything. And I know what that's like. I've been to planning, and sometimes you want to scream, but you know, let the people speak, let the officers explain. They're going to answer, they're going to do a presentation first, and then they will answer each of those questions, okay? But please don't make any comments, because I'll have to stop the meeting, and I don't want to do that. And I think hopefully we will get the answers we want. So I'm now going to ask each officer to individually introduce themselves and then do the presentation, please.
Thank you, Chair. I'm Alison Rouswell. I'm Director of Localities and Strategic Commissioning at NHS Somerset Integrated Care Board, so known as the ICB.
Hi, Chair. Charlie Davis, Dr. Charlie Davis from the Palliative Care Consultants and the Associate Medical Director of Communities at Somerset Foundation Trust.
Good morning, everyone. I'm Andy Heron, Chief Operating Officer and Deputy Chief Executive for Somerset Foundation Trust.
Hello, good morning. I'm Cathy Dorian. I'm the Deputy Service Group Director for Somerset Foundation Trust for Neighbourhoods and Community.
Could I ask you all to bring your microphones nearer to you, please, as some of you may be difficult. I want everyone to hear everything you're saying. Over to you, Alice.
Thank you, Chair. So we're really pleased to be here today to talk to you about community hospital services, and we're really keen to get the views of the committee and the public. I'm going to hand over to Dr. Charlie Davis to give an overview. We recognise you all have the paper. I'm sure you've got lots of questions already as well, and we'll be very pleased to answer those as well.
Thank you, Alison, and good morning, everybody. I'm sorry that I've got my back to members of the public. It's the way the room's set up. It's not deliberate. My apologies. I'll speak as best I can. I'm Charlie Davis. I'm a doctor, a palliative care doctor. I look after people who aren't going to get better, sadly, but we try and make sure that the life that they do have is as good as possible, and arguably that they can still get up to some mischief and have some enjoyment even in a tricky situation. That really informs my life and my job also as an NHS clinical manager. And I'm someone who both works into community hospitals, works with community hospitals and manages community hospitals. And I'd like to say a few words today about them, but also as a citizen of Somerset. I've lived here since 2014 when I was a consultant and appointed down here, and I live just outside of Shepton, a community hospital that did have beds and no longer does, and as part of the Shape Mend It work is very successful in what it does for its local community, and that will only grow and improve. As a manager, these experiences that I have alongside people who are dying or in the last bit of their life really help me understand the importance of community hospitals, care at home, but also the difficulties sometimes of care at home. This temporary reduction, this looking at community hospitals and how they work into the future is really important. but it's not without its difficulty. It's a real challenge. With a number of members of the public here today, we've had a number of very searching questions, and I thank you very much for that. We all do. This is part of engagement, it's part of scrutiny, hence the committee's name. It's part of us ensuring that we haven't missed anything, that other people, yourselves as the councillors, as the committee here, and our members of the public can help us with. The NHS is a broad church though. It's a cradle to grave service at its inception. It's something that then is reflected in that in community hospitals. And all of our communities think very fondly of their community hospitals. The process, the people gathering, the swathe of opinion, the energy for people to try and ensure that their community hospital is standing and doing what they need it to do into the future is shared by us here at SFT. We need to concentrate today, if it's okay, about community hospitals. A number of our questions were broader, and I think it will be difficult in the time that we've got to answer all of those today. And we have provided some answers, Chair, to those for future options to come and speak to us at SFT. There are times when community hospitals really strike me as being different. There are times when community hospitals all follow something that's really quite magical. That a local community has an identity, has a place that it perhaps passes regularly, that it sees, that is the emblem of its health and its healthcare. And the good that they do, it's interned in the fabric of the very building at times. And we heard earlier of some of the older buildings that we have and just how important they are to people. But services do need to evolve. We don't run cottage hospitals anymore. We don't have convalescence wards. We have inpatient stays specifically to try and help people to get to a state of health when they can return to independence, or recognise that if that's not going to be possible, then they have an onward journey to a place of care that perhaps wasn't the one that they left in an ambulance, perhaps in the middle of the night. These changes are difficult. They're difficult for us to think about. They're difficult for us to know what the best thing is to do. They're difficult for members of the public to really think, well, okay, how do I see this and what's the detail of it? And that's reflected in some of our questions today. But I wanted to really have a think about bedded care, a little bit of generalism about bedded care, and some things to try and get us on the same page of what I see with people, not just in end-of-life care, but those who are perhaps increasingly frail and elderly, and those that are perhaps recurrently in beds. One of the things we know from an audit up in Scotland is that for any given hospital, around 30% of the people that are inpatients in it on any particular day are likely not to be alive in a year's time. One of the challenges of that is that we need to make sure that we're not wasting that time in an inefficient system that keeps people away from home. Being away from home and not in your own bed, frankly, is a dangerous pursuit. You'll be socially deconditioned, you'll be out of your community, you won't be necessarily around your family and friends. Your family and friends may find it difficult to come and see you, particularly if your neighbour perhaps is also frail and can't travel. There's a decrease of around 10% for every week that someone's lying in a hospital bed or not doing their normal levels of activity. This deconditioning in a very short space of time physically can mean that people can't return to an independence that they perhaps would not have lost if they were treated and looked after at home in a more proactive way. And our community hospitals in their role in rehab and how they help people to recover an independence despite these losses whilst they're receiving the care that they can only receive in a hospital when they have had to leave the home because there was no viable alternative, is a really important part of now, and it will be a really important part of the future. But we must really only use hospital beds when they're needed. And that's not because of changes in numbers or ability to staff them or anything like that. It's because being in a hospital bed is a dangerous pursuit. Unless you have to be there for a need that only can be dealt with there, we should move people to being looked after at home and as near to home as possible. I wanted to try and get us on the same page around some of the comments made by our MP colleague around sickness. Sickness is an interesting concept when we think about it alongside illness. If I were to phrase any one of us who hopefully is in reasonable health, we may have a sickness that's short-lived, we're likely to get better, perhaps we will or won't need a hospital or a doctor, and then we'll recover to a level of health very similar, if not the same, as to as we are soon. For people who have chronic illness, for people who are elderly and frail and who have an increasing difficulty to keep up with their comorbidities, when they become sick, when they exacerbate their health, their ability to decondition and decline very quickly is profound. So sickness and getting better are not necessarily the same thing. For elderly people, the ability to get better might be a return to a functional state that isn't as good as it was, but is as good as it can be. Languishing in a hospital, being stuck in a hospital, not being able to have services locally that can look after you at home to ensure that your rehabilitation and your independence is done in the environment that you would normally live in, mean that it's less likely that you will go back there. I want to make sure that we're thinking about the alternatives as well to this community hospital plan. The alternatives in there, put quite simply, and I do have to be simple with these things at times, is to say that home reablement, the ability to keep somebody at home, treat them whilst they are at home for their medical needs, and ensure that they don't decondition, and what reablement they need is done within the home without leaving. It's an important strand of what we want to do. But also to ensure that we offer through our community hospital sites, through our services, that we offer this, it's been mentioned before by people, the neighbourhood health centre, the hub type model. And Somerset in that regard is very lucky. We have a number of community hospitals. They have wards at the moment, they have beds in the main. There are some that don't. They've made a transition away from beds some time ago. But we're lucky to have them in great locations. We're lucky to have good setups. We're lucky to have access to them that's relatively easy for people. They're lucky to have bus routes, etc. And they're already part of their communities. We've already heard from League of Friends colleagues as well of how important they are, but they're there and they're embedded. Their ability as part of the 10-year plan to become local community and neighbourhood units and hubs is really important to us. We want to achieve within all this a move to health, be it diagnostics, be it outpatient care, continuing things like our urgent treatment, but ensuring that where possible we look after people at home rather than away from their home in a bed that's one of ours for all of the reasons stated previously. I wanted finally just to leave on a note that comes rather personally as a palliative care consultant. I'm always going to need some form of bedded care for my patients. Many of my patients plan to stay at home, but when the reality dawns of when death is coming is going to be like, or their family are tired and they can't manage, we will need care away from that home. At that point, my experience with families is that as long as people are looked after well, hopefully in an area that's close by, but not in an acute hospital in crisis with the chaos of going through an emergency department, then it is sufficient and they can set up for those days in their end of life to be looked after well by a team that will offer them love and support and care. Community hospitals are an important part of that, and they will continue to be so even as part of this plan. It's something that I don't think I could practice palliative care in Somerset with if we didn't have some form of bedded care away from people's homes that wasn't an acute treadmill, if you like, of care that comes from an emergency department. This change is really important to me. It's really important to me personally because I plan to live here and hopefully live out my days in Somerset. So what happens to healthcare is important. It's really important to me professionally. I know it's really important that we've got viable alternatives that's needed to home when they're needed of bedded care. That's part of the plan. What we need now to do is engage with the public, as everybody is asking for, and have a think through on a local level. What is it that a population needs? What is it that they want? What can be managed? What can we do? How can we best help? Those answers may be different, and it's one of the reasons why we haven't been able to come up with express detail beyond ideas. Some things like chemotherapy, for example, things like ambulatory care. These areas of care, if we can expand them, should help proactively to keep people well at home, not getting into crisis. If they then do need treatment because their health needs to escalate, then we can provide that care closer to home. That's the exchange here for not having beds at community hospitals. We're going to do it on a temporary basis and see how things are, assess it, and then make a sensible decision at the end alongside members of the public. It is a challenge. It brings about a grief that I see in my clinical work when we make changes, when we think about changes, when we experience something that could be a loss. At the moment, we're at a phase of all of this process where we come to committees like this, we try and engage as best we can with members of the public and try and reassure. The challenges at the moment without engagement with communities to understand exactly what's needed, what's wanted in their populations, and that rightly is to come. It takes some time to do. But we're not going to come with a prescription. I'm not going to come as a doctor's prescription and say this is exactly what you need and it'll all be better. We have to work with communities to do that. So this is important to me as a doctor, to me as a citizen of Somerset, to me as someone who hopefully wants to stay in Somerset and isn't moved on by days like today, and also as a clinical manager. My last bit really is to the staff of SFT and for those affected by it. We've worked really hard to try and proactively help and support them in also what is a really difficult time. And I know for those members of staff, there are lots of questions and things that we're trying our best to answer. It is a state of change. Change is really challenging, but it has happened before and we've had good outcomes. Committees like this are really welcome to us, to give us the scrutiny, to give us the questions that are likely to lead us in slightly different directions. But the direction that we need to discuss today is about the community hospitals. I thank you very much, Chair, for the time.
Thank you. Thank you very much. Thank you. Over to us. No one else wishes to say? I think, can I just start this by, I think most of the members of the public feel that this is like the chicken before the egg. You know, they weren't given the opportunity to be asked first, what do you think? You're giving the explanation, and what you're really saying is you won't know how it's going to work unless we try it. And like, we get that. What we want you to know is, as a scrutiny committee, we want to be with you every step of the way. So, you know, today you may go away, but we're going to have you back. And not to be horrible, but Doctor, I don't want you to leave because I may need you. But the thing is, we need to keep on this. This is what we do. We do well. We scrutinise everything and we do it constantly. So we want the members of the public to feel confident that if we're doing this trial, that they are on board as well. All their relevant questions they asked today were really, really important. And you know they're important. So I think it's just understanding that measure from them, that they feel that they were excluded. And, you know, and I'm a member of public and, you know, but I wonder whether our portfolio holder could explain about the Newton Europe, could go into I'd like her to explain a little bit of detail about where we as a council, where we focused our travel. That would be all right, Sarah. Thank you.
I was hoping you were asking me, actually. Thank you. I think people on this committee will probably know that as a result of having input and a partnership with Newton Europe, in My Life, My Future programme, it was all about re-ablement and using our statistics that we get in our team better to see people into a better situation more quickly, to keep people at home for longer, and to make sure that they could go back home, which is where most people want to be. I was very interested listening to Dr. Davis just talking about this, because it's exactly the thrust of what we are doing in adult social care. And putting people in a bedded situation, putting them out of an acute hospital into a community hospital, unless they really need to be in a bed somewhere, and we could probably put them in a care home if that's what they really needed, or we could get them something at home with all the tech support that's now available, using our Somerset Independent Living Centres that they can go to and get some of that tech support. The difference is that there's no point in being taken out of an acute hospital if you have what we call no criteria to resign. In other words, you're not being treated actively for a medical condition to be put in another bed. It just makes you less fit to carry on with your life. And I just want to re-emphasize, and Dr. Davis made it very clear, but that's the problem. We don't want to keep putting people into beds when they should be up and walking about. My father went in hospital for a week. He came out and he couldn't lift the kettle when he got home. He was 95, but that's what happens. And it happens so quickly that we are changing. The NHS is changing. It has changed for years. I remember all through my life hearing about bed closures and thinking, why are they closing beds? But my father went into hospital when he in his 40s had an appendix out. He was in for 3 weeks. They come out the next day now. We deal with people differently. People are growing older, living longer. Quite a lot of us, hopefully, in better condition and with more aspiration about carrying on with our lives as long as we can, rather than just saying, oh no, I give up now, I'm going to sit in a care home for 10 years. People don't want to do that anymore. And I just think that it's really sad. I'm sorry about the local hospitals where people really worry about loss of beds, but that doesn't mean that your loved one won't be dealt with properly. Hopefully they will be dealt with better, more closer to their needs, and with the re-ablement that they need to get them back to the sort of life they can carry on living, perhaps as was said, not quite as good as it was. That happens to all of us. And I think, that is the way we're going with adult social care as well. So we're absolutely in tune with the sort of way that the health service are looking at this.
Thank you very much, Sarah. Thank you. The other thing I'd just like to add, if I may ask, if you could just expand on for me, is the fact that, you know, the bed spaces, Bridgewater was 30, it's coming down to 24, Frome is 24, coming down to 16, West Mendip is 30, coming down to 16, and the consultation has already started about other areas, and we get that. What I think we need to understand is as well, we need to understand not only the benefits to people, but we need to understand the benefits of what you're going to use, what you're going to be able to bring into the hospital. My own husband is a counsellor, and he's been able to go to Bridgewater to have diagnostic testing and scanning done. I think we need to, can you explain that and expand on that? That the benefits of doing this will also be an enablement for better other services, where people don't have to go to Yeovil, Frome and Musgrove, because actually you can provide it in these hospitals. I think if people can understand the benefits, that will also help as well, please.
Thank you, Chair. The community hospitals represent a massive opportunity in this space. So the 10-year plan is, in my view, perfect for Somerset. I spent quite a lot of my career working in London, in Bristol, in urban areas. And to be honest, it is so much more difficult delivering healthcare to a rural population because the previous model of care that we've had has been very much centred around large acute hospitals. This is our time, and the community hospitals, if we didn't have them, we'd probably need to go out and get them. They represent a fantastic opportunity for a lot of those services on our acute hospital sites to come out and be brought closer to local communities. It's a really tricky one, this, and I know there's a lot of concern around how we've approached this, around, but we're not giving a very definite plan. But in truth, what we want to do with local communities is to have a conversation about what's important to those local communities, and also to show those local communities what services they are currently using in our acute hospital sites, which is also a very important part of making decisions on what comes in. So we can talk about, for the moment, before we've done that engagement work with local communities and with town councils and anyone who will talk to us, we can talk about a menu of possibility. I'm very happy to do that, and it includes things like urology. It includes services like chemotherapy. If you come to the Beacon Centre at Musgrove Park Hospital, which we also run, of course, you'll find people almost spilling out into corridors there, such is the overcrowding within the Beacon Centre. And in the last couple of years, we've begun to deliver chemotherapy out in community hospitals, and there's so much more potential for that. At the moment, our community hospitals are not especially well used by children and young families. Of course, there are huge opportunities with some of our paediatric services to potentially bring those out with community midwifery, with the list goes on and on. In terms of diagnostics, the very early parts of the conversations that we've had at the moment show just what value people in local communities place on diagnostic capability within those hospitals. The X-ray is tricky unless you can get me a busload, maybe 3 busloads of radiographers, but we do that where we can. Ultrasound diagnostics and other forms of diagnostics, there's huge potential to bring those to our community hospitals. So what we would eventually, at the moment, we want to talk to people about what is the right mix of beds and how we use the floors. If we didn't run so many beds, what would you use the floor area for? There are all sorts of possibilities with that. In terms of what we eventually put there, if we do reduce beds, then that will be partly a reflection of those conversations.
Well, the honest speakers, I just want to go to Councillor Gogan, then I'll go to Councillor Sunny. Okay, Councillor Gogan.
Thank you, Chair. Andrew Gogan, Wellington. I was involved with Somerset Primary Care Trust a number of years ago, and at the time we were responsible for delivering the community community hospitals. And I went through similar concerns about the future of community hospitals and was called in, as they knew I was on the PCT, by the League of Friends at Wellington Hospital because they were concerned about the closure. So when I heard the proposal to formalise the closure of the beds there, I assumed the League of Friends would call me in and be saying, what am I going to do now as a local councillor to do that? But I was quite surprised that when I did receive a contact from them, and I know I'm conscious when I'm saying this, areas across Somerset are different, and the services that are provided will be different to people. So I may not be speaking, for people in Burnham or Wales or wherever, but this is the experience that the League of Friends, who are people of passion and raised a considerable amount of money for the hospital over the years, said to me that they in fact welcome the changes that as the fact that the 10 inpatient.
Could I just, sorry, councillor, we've got a bit of a sound problem. Not yours, but unfortunately not coming through. Can you just hang on 1 second?
Yeah, of course. Sorry, Chair, those online are now all of a sudden the sound has become quite tinny and reduced, and they're missing more than half of what has been said. I'm not quite sure the reason would be because Councillor Goby hasn't used his microphone up at this point. So
can you bring it very near you?
Yeah, of course.
And everybody bring their microphone to the air.
I think it might have been even before Councillor Goby started speaking. But, shall I try listening online? Well, shall I try again? Is that any better? Or those at home, could you please indicate whether you can hear me or Councillor Goby speaking? But is it clearer when I'm speaking than when Councillor Goby was speaking? My only suggestion to those listening online, because we can't really do a lot with the equipment that we have in this room, is to put the subtitles on. So we can put the live captions on. They're not always that accurate.
You can't hear nothing now. You can't hear nothing now.
Is that the case? Sorry, could anyone indicate whether the sound has totally dropped off at home now?
That's clear.
We're going to try putting the live captions on the feed. The sound hasn't obviously changed within the room at all, and none of the microphone batteries are indicating that they're running out. So I'm not quite sure what the issue is. The meeting hour that we're using to webcast the meeting is fairly limited in its usability. So there's not a lot we can do to address that. So Chair, it's sort of, are you happy to continue?
Yes, I think we have to. I apologise to those at home that can't hear very well, but I think if everyone does make the effort to speak up as clearly as possible, that will help. But we just wish for the best. So I'd like to go back to you, Councillor Goby, please.
Yeah, thank you, Chair. So I just recap, and not all of what I was saying, but basically I was getting to the point where I expected there to be concern about the loss of the beds in Wellington. But I was actually contacted by the League of Friends. The League of Friends asked me, and I attended Wellington Community Hospital, and they told me the transformation of that community hospital from a 10-bed inpatient, which provided most of the time it was elderly patients. Most of the time it wasn't at full capacity. The cost of running that unit was prohibitive, and it really wasn't delivering for anyone else other than the elderly at a point, I guess, with the younger people and that sort of thing. They now told me that, and I went there and I witnessed it myself, and I've also witnessed it in a clinical sense for going there for scans, that the hospital now operates 5 days a week, hosting over 30 clinics for serving patients across all age groups, from the youngest with newborns to the elderly, and it provides services including antenatal care, ENT, speech and language therapy, ADHD support, psychology, ultrasound, stroke care, audiology, diabetic retinopathy, and many others. And there's looking to provide even more services there. They also provide, I think was touched on there, services from the Beacon Centre. So this effectively means hundreds, probably thousands of people who live in the Wellington and surrounding areas are now able to access services much closer to home in Wellington than having to go into Taunton to Musgrove site, which is crowded, expensive to use, and that sort of thing. So I'm not saying this model is the model that will work across the whole of the county, and I wouldn't wish to downplay the concerns that other people have got. But I think what I am highlighting is that people in Wellington who are close to the service, as in the League of Friends, are highlighting the success and the transformation. They're very keen for there to be more clinics there. The staff are on board. The staff think it's transformed their jobs. It's made their jobs more interesting. There's more opportunities for them to progress and train and that sort of thing. So, and we're very excited as a local town council to engage with the NHS to try and make sure that we can deliver the best services locally, accepting we've lost the beds and that, that there are people who think, the beds are important. But I know it's our own model of care, as I think Sarah Wakefield just said, that we want to try and get people discharged safely from the district hospitals into their own homes with appropriate support packages in place. And I know from having elderly parents and relations that is improved dramatically over coming years, and also things like the I wouldn't call it the wrong system, but the pipeline system, which provides support to people and the services. And as I think Sarah said, the tech that's out there now is transforming the delivery of services to people post hospital. So I don't want to say whether it's right or wrong for each individual area, but a lot of people in Wellington are benefiting from the changes that have already been made and hope to benefit more in the future.
Thank you very much, Councillor Goby. That's really good to hear. It's nice to hear both sides. I know in Bridgewater we've got a similar situation, but of course it's good. The one thing I do want to come back to in a minute is about the staff. I think that's a very important factor. We need to know how protected our staff are. But over to Councillor Sully, please.
Thank you. I think it is very different. I think we need to think about the whole of Somerset here. I understand the vision, and I think everybody understands direction or where you want to take us, but I'm just confused about the plan, details of the plan. There's a 10-year plan, but how will this look at our local community hospitals? And you're asking communities to help you with the plan, but you're already closing beds already. So I feel it's very confused. I've got some questions which I have sent you in advance, and I wanted to not put you on the spot. I'm happy to take some real answers as well, but I just want to summarise the questions, if I may. Staff are members of our community as well, and they've been coming to their local representatives, town, city, and at the unitary, and they've expressed distress and anxiety regarding these changes. Your consultation with them stated that where natural turnover is not possible, a competitive selection process will be followed competitively. And for those not successful, redeployment options will be offered with the possibility of redundancy if no suitable alternative roles are found. I've asked in my question, do you recognise the unhappiness that this has created? And I've heard some have commented on an experience of toxic work environment that this change process adopted has created. And in the last 24 hours, I've had messages. Hi, I did not keep my job at West Mendip, all locations of big hospitals like the Oval Crystal Bath. I will probably leave the NHS after 25 years. Another message. As one of the staff, I've been told today that I have no job. I've been in the NHS as a care assistant for 38 years. I now feel that I have been rubbish throughout my career, even though I've had good reports. This is how good, reliable staff are being treated. I guess that's the process there. So that my first question is, do you value the staff? See those examples. I know other town city councillors are also getting similar messages. In your communications to staff and in your presentation, you talk about unsafe buildings, which rings alarm bells with me. You told staff that some of the community hospital buildings are in poor repair, and this is a reason for closing the beds. Could you tell us which hospitals you consider unsafe? And I know that you've written to Burnham-on-Sea and you've talked about a budget of 250,000 for the maintenance, so you have a plan. But I would like to know the maintenance budgets for all hospitals. And is there a threat to hospitals because of safety? Third question, care home bed closures. In your internal communication, you've talked about 3 care homes having bed closures in Martop, North Petherton and Glastonbury, all 16 beds are being removed. And I just wondered what the reasoning behind closing the beds in care homes when there's different types of beds, so I do understand that, but you're going to need care homes if you have less beds in the community hospital. And my fourth question was, would you consider pausing and reflecting after hearing the concerns that you say you welcome from the community and seeing how people have come out to support their community hospitals? You talk about test and learn and temporary measures. What does temporary measures mean? Can you roll back this? Can you roll back the contracts? How do staff stand when their contracts are being changed? Is it continuous employment for somebody who has worked 25 years or 38 years and they're redeployed? Is it continuous employment? So I don't know if you can come back to me with any of those today, but I think as I started out saying, I'm confused as to what your actual plan is, because you're asking people to help you evolve the plan, but I do understand the sentiment and the vision and giving people the best care where they need it. But what's the details behind your plan? How will the hospitals look? What is the future of our community hospitals? Are you going to close them? Thank you.
Claire, would anybody like to respond to that, please? Individually, yes.
First of all, hopefully you can hear me. Thank you, Councillor Sully. If I can take the question about colleagues, if that's okay, and then we may need to reiterate some of those other ones. We've got many other colleagues that be able to take those questions. So for colleagues, we've been very closely involved with our colleagues during this process of formal consultation with them. That's through contractual employment law, and we've been doing that alongside our HR support services and our wellbeing services. So they've had wellbeing support all the way through those processes and have been supported all the way through. So the recent last 24 hours are that we've met with our senior leaders on those wards and had conversations about redeployment options and those for those who have been unsuccessful in obtaining or keeping the jobs permanently within the wards that we have that we've retained in those hospitals. So we've always said that there would be nobody at risk of redundancy. We've never had in our papers that there would be anything that anybody would be at risk of redundancy. And in fact, for lots of our colleagues, it's created amazing opportunities for people. And only we haven't completed this process. So let's be absolutely clear. We're now in a redeployment plan for about the next 2 weeks now. So we have no conclusion as to what that will look like for colleagues in this next period of 2 weeks. But we have plenty of opportunities to be temporarily redeployed to other opportunities. And in West Midlands in particular, there are a number of registered colleagues who are really excited to be having opportunities in our urgent treatment centres and in some of our acute sites as well. But the other bit that was at the end of your questions, the very final one about continuous service absolutely does continue. So just to answer that bit, they will have continuous service. And this is only a temporary redeployment process. So if we were to need to reopen those beds, they would be the first colleagues that would be in line for coming back into those original jobs that they had. So that's the answer to the colleagues. But we're in a process now which is quite sensitive in this next couple of weeks, where we are having conversations with those just to answer that colleague. Just saying, I have actually seen it in writing that you have stated to staff there's a risk of redundancy. You just said then on record that you haven't said that. So could you? Because I've actually have seen that. I've got it in front of me. Okay. Risk of redundancy. Is that true or not? We don't have any. We haven't got risk of redundancy to the colleagues we've got in this phase at this moment in time.
I think that can be looked at outside of this meeting. That's okay, because I think we don't want to be talking about individuals. Okay, anyone else would like to?
Thank you, Councillor Sully. I'll come in on the safety issue for the buildings, if that's okay. All of our buildings are safe, building care that they are delivering at the moment. But of course, safety standards only ever go up, which is quite right, and they should. And for our modern buildings, many of our modern community hospitals, that's absolutely no problem. They've been built to the highest standards, and then there are extra standards for healthcare buildings that we need to meet. For some of our older buildings, where we currently deliver bed-based care, and in particular with Crookhern and Burnham-on-Sea, there are challenges in those buildings. They're quite old, very old in the case of Crookhern Hospital, and they don't have, and I'll just stray for a moment, if you don't mind, into the territory of fire safety. They don't have the degree of compartmentalisation that you'd find in a modern building. So, i.e. the ability to shut off part of a building, and the building will hold a fire for a certain period of time to allow evacuation. That impacts on who it is that we can take into those two hospitals. So in response to fire inspections and our own internal fire reports, we've now had to limit the kinds of patients and numbers of patients that can go into those hospitals who are not fully ambulant, or who we perhaps would struggle to evacuate. And you've always got to take the worst case scenario if it's 3 a.m. when there are least staff around. So they are saying they're just becoming increasingly limited in who we can serve through those buildings. Now, having said that, we continuously do what we can to improve them. We spent a lot of money last year on the new fire system at Burnham-on-Sea Hospital. We'll be spending more money this year to try and achieve greater compartmentalisation, and we'll also be spending money at Crookhern as well. So it's a continuous process of investment. It's just harder and harder to keep up with modern standards at those buildings.
Can I just get an answer about the care home beds that you're closing, please? Thank you, Alison. Just also one other thing to note. So you've asked about the test and learn and whether the changes could be reversible. Absolutely. So as an ICB, we'll be overseeing the test and learn, and if it doesn't deliver what it needs to, it will need to be reversed. So just to make that really clear, I'm going to hand over to my colleague Paul Coles to answer about the care home bit.
In relation to the care homes that we're proposing to reduce the units that we have currently within them, some of that is due to the cohort of people that are utilising those units. A lot of the people moving into them are people living with dementia and coming to that advanced stage of the dementia journey. The units were set up originally to enable us to undertake a settlement process of these people. We call it Pathway Free, which is our opportunity to assess people that we know need long-term care. Ultimately, for us as a council and for our colleagues within the ICB as part of our partnership approach in this space, we know we're not getting it right for people living with a dementia, and we're moving them 2-3 times, which if you know anybody that has a dementia diagnosis, that's totally the wrong thing to do for these people. So ultimately, we want to get it right the first time round, and where we've identified from the acute, when they've been in the acute setting, that they need a long-term care provision. Let's just move them to that care provision now, rather than moving them into an interim placement and then moving them again, because ultimately we are doing a disservice to the people of Somerset here. So those beds currently that we have within those 3 sites are going to be closing over a period of time, but we continue to work with those providers to ensure that the capacity remains to be able to support people for their long-term care needs rather than on a temporary basis. In relation to Glastonbury Care Home, we're not going to be closing the whole 16 beds at this moment in time. We want to be able to test and learn this space. So what we're looking at doing is reducing the beds down to 10 beds to be able to work with the home and work to ensure that we're meeting the needs of the population going forward. And ultimately, any funding that we have has gone into our D2A delivery, so enabling people, as we have through consultation with the public, as part of our home care delivery and other aspects, people want to be at home, and therefore we're enhancing the number of hours, we call them slots, that we offer in relation to discharge out of hospital for people to go back home. So at the moment, we kind of it's around 60 slots per week, and we're looking to up that to 87. So that's enabling people to get back out into their community, back out into the home where people want to be. We all want to be in our own beds. We don't want to be in that interim period.
Thank you. We need to move on now to other councillors who need to ask questions. Did you want to add anything else? You're happy? I want to bring everyone else in if I can. Councillor Trimnell, please.
Thank you, Chair. So I have a couple of questions, basically. I wanted to say really that I recognise the need to try on this approach. I understand why we need to do this, because I've been in hospital for fairly lengthy stays. I couldn't wait to get out there, but what I often noticed, I was on wards mainly with elderly patients, was how they perked up actually at the mention of going home, at the packing of their bags and having someone to collect them. It does make a difference, and I think everybody ideally would want to be at home, provided they know and they have reassurances that the care that they need when they get home will be in place. And I think that's really important. I don't doubt that you'll be looking into that. I found it shocking to hear about the deterioration of people in hospitals, and I'm assuming you mean when they're convalescent rather than when they're ill, because illness will naturally decondition you, but I'm assuming that actually once you go into that sort of convalescent space, as it would have been called, that deterioration continues, and that's not a good thing. And so I do understand why we need to do it. I think that the aim of having those greater facilities for more people in those spaces, bringing those treatments locally for people so that you don't have to go into Yeovil or Musgrove, park up all of the, like you said, the queues and chaos in the sort of waiting areas and things. So I think it's really welcome. I do take on board some of the concerns that people have about it, and I think that you are answering those, and I presume you will continue to answer those. But overall, I'm pleased to see this trial coming forward, provided you can give reassurances, I suppose, that if you find that it isn't working, that you would be prepared to revert back to what was in place now, to look at other alternatives or how it could be managed better. And I suppose in our role as Scrutiny, we're not here to give you any kind of medical advice or anything, because they speak for me, I'm not medically trained, I wouldn't have a clue. But at the end of the day, what we have to do is to be able to look at the evidence and the data that you present to us that shows us either it is or it isn't working. And what I wondered was, what will that look like? What are those signs that you'll be looking for that give you the indications that actually this is working? Are we looking very sadly at the number of people who are taken back into hospital or who die as a result of this, compared to how it's been under the current situation? Because you're going to come back, I'm certain that you're going to be inviting them back to tell us how things are going, and I want to know what I need to be looking out for. What kind of things you anticipate, please? Anybody wish to? Which one?
Thank you for that. Absolutely. One of the things we want to make sure that we do is come back, keep you briefed on where we are, and actually involve you as much as we can along with the public in how we can co-design our future community hospitals. Just to come back on that, as we said, we have a range of measures in place that we'll be testing out on the test and learn, making sure that it's delivering what it needs to do. We will be evaluating that. So again, we're very happy to come back and provide you with the evaluation of where we've got to. There are a range of different metrics that we are using to be able to test that out. I can go through them now, but absolutely we will do that if we come back give you the briefing, but I can read them out if you would like me to, but.
Well, possibly, even if you write it, if it's written down, whether you send it, whether we can be sent it now. We don't want to take the meeting too long. I don't want you to have to read out lists of stuff, but it'd be really interested to see what will be needed to evaluate when it comes back to us. Thank you.
I think the one thing that's come out of this is that many people think it could be stopped, this trial. It could be stopped until we have. The problem is with a trial, you won't know if it's going to work until you trial it. So we're in a difficult position. What we want to do is make sure that we are working with you, but also scrutinising you. Make no mistake about it. You know, I always joke about Tandy, I'm the enemy. But in a way, what we want you to know is that we are scrutinising every way. We sent the letter to the Secretary of State about the Yeovil Hospital closure and about the trying to get Yeovil building done. That's how we are strong in this committee. We're not messing around. We believe in what we say. So I think it's important that you gathering today and all the members of the public that brought such great questions, they were valid questions. They were valid because some of it today you've clarified a lot of points, but in a way in life you want to deal. And what we want to know is if you're going to close this, then what are we going to get in its place? What are you going to give us that's any better? And it has to be that way. We have to see the benefits, why you're doing what you're doing. So we will want you back. We want you back very quickly. But I just want to let you know that. Keep that in mind, Andy. You're not going anywhere. Okay. I'm going to go online now. Is there anyone else that wishes to speak? Emily, apologise, Emily Postone, Councillor Postone, sorry.
Many of the bits and pieces that made me questions have actually been answered. One of the things that I'm fearful of, and it may be a bit divisive, is that by reducing these beds, by trying to keep people at home, trying to find ways to reduce costs to all of the taxpayers when it comes to caring for people, most often in waiting, is that yes, people want to be at home. There are carers at home that inevitably over time struggle more and more. That concerns me greatly, and I do not believe that there is enough support for those people far from it, because they are responsible for moving their relatives or encouraging them to take care of themselves when during times of the decline of mental acuity, often self-neglect occurs. These things, when people go into hospital and community beds for whatever reason, often it's because of comorbidity, whether it's they've had a fall and damaged themselves in some way and they need that extra bit of care. I just worry that people aren't going to be noticing other declines or other harms that are going on within the home setting, because the knowledgeable, highly trained staff that are in those community hospitals, that experience where they can look over at a patient and just know that there's something not quite compared to yesterday. The thought that those things are lost when wonderful, wonderful care staff go in for 20 minutes, half an hour, morning to go and help somebody at home won't be picked up. Whether it be a urinary infection, which is that concerns me. Those losses concern me, that we are going to be losing experienced staff and that experienced knowledge, and people are just going to be disappearing. Not to be seen, not to be noticed by visitors that are visiting another patient across the ward. And is that personal? I don't know. That's my concern. And I appreciate that you're still keeping beds open. I appreciate that, as Jill said, there has to be a trial to know whether it would work or not. But if you're going to be bringing where from, who knows, all sorts of diagnostic equipment into that space that you've just removed these beds from, the ease at which reversing, should it be needed, isn't going to be that easy.
very good point. I mean, I would assume that you wouldn't put the equipment into until you know this is going to work. I'm assuming this is common sense, surely. Yeah, thank you. Just wanted to, I'm going to put you to our portfolio holder, Sarah Wakefield, please.
I just wanted to reassure people who are listening to this that when it comes to caring, we do have a carer support service. It's commissioned through what is now known as Thrive, of course, the Community Council of Somerset, and they are there to support carers. Now, the point about all this is you have to ask for help. It's like when you go to the doctor, because you need help. So if people don't ask for help or say, I don't feel quite right, or I need the doctor, they won't get to it. That's absolutely true. They won't be noticed across the ward. But keeping them in that ward may make it so much harder for them to get home at the end of the day. So I don't think, so that's one of the problems with it. And this is not risk-free. And one thing that I've noticed, I'm not a medical person at all, I'm a lawyer, but one of the things I've noticed is that the NHS, my son is actually a consultant, are quite risk-averse. It's quite difficult to get them to say, well, this patient's going to be just as safe when they go home as they are. They're not going to be as safe because life is risky. But actually, most of us don't want to be confined. And when you're in a hospital bed, you are actually confined. You're not locked up, but you're kind of up in a place where it's not, most people don't want to be. So I just think we have to understand that life isn't risk-free, but actually I would rather be coping for myself at home than not being there. And most people, now some people say, no, I don't want to do that. My father did it. He was in his 95. He said, I want to go into a care home. And I said, really? You can just about manage. But actually, he was beginning to slow down. He died within a year, which is absolutely difficult. And he had enough. But not everybody does that. But I just think you need to understand that this is not risk-free. None of it is. None of what we do, keep caring for people at home, with people going into care for them 7 times a day sometimes, it's not risk-free. But it might be, hopefully, what that person wants, not always what the family wants, but hopefully what the family wants, and what they regard as real life. Because real life is not being in a hospital bed.
Thank you. Thank you very much, Sarah. Thank you. Councillor Rodriguez, please.
Thanks, Chair. Thank you for the presentation and the chat today. I do want to say that this is obviously a very emotive subject. And personally, I just want to say it's a great shame that outside of this room, in my opinion, being far too politicised. People are very emotive about this because it matters to us, to our health, our own experiences, and family experiences too. So I appreciate the sensible debate in this room. I can see that this could work. I've read what I've read in the papers. But I just feel like perhaps as a committee, I know it's been mentioned about the metrics and what have you, that this committee really needs to be kept in the loop about monitoring the changes, the trials, performance, how it's impacting the good and the bad, the ugly, all of that sort of stuff to keep us in the loop and to be able to bring our residents along with us too in this journey, if it's a journey that we're going to have. I think as patients, as service users, I think, we all need at some point need the reassurance and confidence that having any care at home rather than a community hospital does work and is the right thing. I had a kidney procedure a couple of months ago. It was only a day thing. Left, passed out on the way home, went to complications, had to go and stay the night. So for people who have that experience, that's just me, I can deal with that. But when people have that sort of experience, you wonder actually, I would have felt so much safer staying in that hospital a few more hours than going home. And will I have received the same amount of care at home had I been at home? So there's that confidence and reassurance that people need that they get the right sort of care. And the other thing around freeing up bed spaces in community hospitals. Following my procedure, I was up in Bristol. I've been back once. We have to go back for a scan in a couple of months' time. Then we have to go back again to see a urologist after that scan. I've got a life to live. I've got money to earn. I don't want to take my holiday going to Bristol for hospital appointments. So if I can do that in 5-10 years' time, if this was happening to me then, if I can drive up the road to Bridgewater Hospital and be seen to and do that within half an hour rather than taking 3 half days off work, then that's brilliant. And I hope that's the way things go. So it's good. It's good in that sense. The only thing I am confused about, Chair, and perhaps some clarity around potentially doing more stuff, diagnostic stuff in community hospitals instead of having those bed spaces. In Bridgewater, in particular, got news of that £17 million diagnostic centre coming into Bridgewater Hospital. But we also see in the papers attempts to reduction in bed spaces in Bridgewater. I'm only wondering, how does that work? I'm assuming that whatever departments are working together with that, and it's all going to make sense, but some assurance and clarity.
Clear and missed.
I hope so, Chair. Councillor Rodriguez, you make a number of really good points. And if I may just for a moment pick up a couple of other points that have been made by colleagues in the room about wanting to have confidence in community services. They're not easy to see, they're not easy to put a camera in front of, but actually we already have incredible community services and they are huge. We have over 5,000 staff, that's just us, the NHS, working in the community, delivering probably about 1.5 million contacts a year, 250,000 through district nursing alone. The levels of care, and just on the issue of transparency, which I think has come up a few points really, and we're really grateful actually to have you alongside us. We want to be transparent because we're actually excited about it. If there is any kind of debate, it's about what's the best future for these assets that we've got in terms of a tremendous opportunity. But that work that we do in intermediate care, the alternatives to hospital care, has been going on for about 7 years now. It is so closely a partnership then between ourselves and our colleagues in social care. We meet weekly. All of our figures are joint figures. We review those figures together. We got joint posts in that space. So in a way, there's nowhere to hide in that. We don't want to. We're very open and transparent. And I think it's a reflection of the fact that we have actually very similar goals to our colleagues in social care on these issues. We are completely united. But just coming right back down to the specifics of Bridgewater, yes, it's fantastic. We're going to have more diagnostics at Bridgewater Community Hospital. We're going to keep investing in our community hospitals as we can. In many ways, it's a sort of good example of what it is that we're talking about today, because the diagnostics that are available there will be diagnostics that at the moment are only available on our acute hospital sites. Those will come out. There'll be an opportunity for people to get those in local communities. Will help us with space on our acute hospital sites, which are really crowded and which we need to get stuff out of if we possibly can. And those will be for a whole range of people, all ages, etc. But if you come back to the beds, that's really part of what we're talking about. The beds at Bridgewater Community Hospital are almost exclusively used for frail old people. And that's part of the model where we're bringing in new alternatives to bed-based care, which we think are better for people. So you've got the two worlds happening at the same time in the same place there already.
Thank you. Thank you very much. Can I go to Councillor Osborne, please?
Thank you, Chairman. I'd also like to thank the public as well for the questions that they've submitted. I thought they were absolutely excellent, very pertinent, probably took quite a few off an awful lot of our list. And one of the things, may I suggest, that we do at full council when we have members' questions and public questions is we ask our lead portfolio holders to provide a written response, which they duly do, and these are shared and distributed. Would it be possible for you to do something similar for our public questioners, to actually give written replies to some of those questions, which can then be published as an appendix to our own minutes? And we have those answers on public record, because that's the other thing that written questions have a benefit of. You have a public record of what the response is, to share at a later date and possibly use that to monitor whether or not you have been successful, kept your word, and all the other bits and pieces with it. Having said that, I do have a few questions or comments. I'll try and be as brief as I can. In terms of the request you've made to us through scrutiny, I think earlier engagement is critical. And one of the things that has come out of our scrutiny review as a council is that We need pre-decision scrutiny, and it needs to be done as early as possible. So we don't need to be seeing something 90% of the way there that you've already made a decision on, because that's no good to anybody. We want to be seeing that at a very, very early stage if you want to get the best out of a committee. It gives you a fantastic chance to raise concerns, opportunities where you might need to communicate far more clearly, because I suspect there has been a communication issue here, where people don't necessarily realise what the proposals are. We've had community hospitals for a very long time, and to be honest, they haven't, the times I've been in charge, it hasn't really changed that much over the years, and we're now looking at doing something quite different with them, and that is quite a scary prospect as you get older or even younger, or you fall sick and you need those services. So I think that is one of the things, if necessary, the adult social care could set up a working group to work with you in a workshop style way on some of those very early embryonic proposals. However, you will need to report back to this full committee the outcomes and the key points as well that you've discussed, so that it's transparent and there's no going behind closed doors. What would have been useful with this report would have been actual data on bed occupancy. There's no data in this to demonstrate what you are saying about underutilisation. So it would have been good to have had a table of the bed use over, say, a 12-month or annual period. What is it for each of those hospitals? So you can demonstrate that at times there is an underutilisation. Data on the patients themselves in terms of gender and also age as well. Are the beds being utilised by one age group more than another? And I suspect we all know the answer to that. That's just a lack in that report. The diagram you produced, I'm sorry, it makes it look like you've got 5 or 6 silos there. I don't understand what those dotted lines are, linking them. There's not a key. When you do diagrams, they're great. A picture says 1,000 words. Please, could you make it absolutely clear and idiot-proof? Because we're not all Guardian readers and we're not all experts on health. So please do make things clear. It's a good diagram, but I would like to know exactly what you're trying to tell me on that, because the community health hubs on that look like they're isolated from the other bits. Going on to other points, and this is one that does concern me, because as the ward division member for Ilminster, I expect that some of my residents will wind up either in Crookherne or in Shard. I know we're not talking about Shard today, but we are talking about Burnham and we are talking about Crookherne. You have raised the fact that these are very, very old hospitals. They need a lot of money spending on them to keep them up together, and that under recent fire regulations, they cannot now have elderly and frail patrons who I suspect are big users of those beds. So there comes a very difficult conversation here, and that is, what is going to happen to those hospitals longer term? Because there comes a point when it becomes uneconomic to keep throwing money at them like that. So are we looking at a rebuild for both Crookherne and for Burnham, so that you have a 21st century fit for purpose? So it won't necessarily be that same building. It may well be somewhere else that actually is going to meet the needs of those residents better. But it is a difficult conversation. It needs to be a very honest conversation, and it needs to take place sooner rather than later. Just announcing a closure in the way you've done previously, you have formed for this. We know this with St Andrew's beds, with the stroke units, and with others. It sort of almost comes up as a done deal. This cannot be a done deal. It needs to be done at an early stage. It's a difficult conversation to have, but I think at some point you're going to have it, because just pouring money into bricks and mortar isn't pouring money into frontline services, better training of nurses, better training up of healthcare workers, which is going to be critical in order to use this technology at home. I do have concerns as well. This is paragraph 315. You're looking at more use of care homes and also spot care, spot placements. I'm pretty certain when I briefly covered adult social care
that we were looking away at moving from spot care because it can get very, very expensive because you are exposed to the market. And also in terms of where those beds may be. So I think more information on that particular model and why you're perhaps going back to it or utilising it. How are you going to ensure, particularly for people in Crookham and where their beds are going to be closed or not available, that there is going to be a care home available close to home? That may not be the case. And you may have to think about that, because I'm sure that someone in Crookham wouldn't be too thrilled if their beds were closed and they then have to move into a care placement far away from home. Nothing's perfect, but that is a potential risk with that. And how are you going to measure the success and the failure of this? What are the parameters? What's the criteria? What is the difference between success and failure?
Councillor Osborne, can we just allow, I think I'm with the respect, I think there's too many questions there, and I think,
Can I just raise one?
You have to be a genius to remember all that.
Very quickly. Yes, I'm sorry, but I can go back over it again. Rurality is a protected characteristic within Somerset Council, and we actually take that into account. Is the ICB going to take this into account when it does its QEIAs? And if it isn't, I'd like to know why not. There's also another matter here as well, and our middle speaker, Davis, has raised. He talked a lot about palliative care, which is something I don't think I know an awful lot about at the moment. It's all usually associated with hospices. Are we looking at doing more of that in community hospitals because they're local? And there's also another elephant in the room here, because recently we actually legalised assisted dying in this country. It's probably not the right place to raise it. It is a bit of an elephant, but are community hospitals going to be reconfigured to perhaps offer that so as it's closer to home and can provide outreach for those that would like that service at home and who may well decide that palliative care is no longer working.
Councillor, I'm sorry, Councillor Osborne, I'm just going to have to stop you there because we do need these questions answered. So can we just go over to Leah, please?
That's my last one. That's my last one.
Super. Yes, very good question. Thank you. Very good questions.
It's
I'd like some answers.
It does need to be raised as well.
So we will attempt to answer as many of those as possible. There will be a range of us doing that, and Paul, I'm sure, will come in about the care home beds. So just to clarify around the early engagement, absolutely, we are setting up stakeholder reference groups for each of the community hospitals to be able to engage, and we absolutely encourage people to come forward to be part of that and help us inform the future models of care. With regard to the picture that you referenced in the report, that's actually from the 10-year plan. So that's in a national report, which was what was used. So apologies if it wasn't referenced properly. We can absolutely provide data, that's not a problem, around the bed occupancy and the gender and age. If the committee feel that it will be a good idea to have a workshop or a subcommittee or whichever you feel is best, absolutely, we'll be delighted to be part of that and work with you on that. So we're very happy with that. Just want to check now, I don't know whether I'm now handing over to my colleagues. Paul, should we come to you first about the care homes and then we'll come over to this side again?
Thank you, Alison. In relation to the care home proposal that we've got on the table at the moment, what we want to do, as I said previously, is move people once. So at the moment, we're moving people 2 or 3 times because we're placing them into one of our blocked commission beds within our intermediate care services. By doing the spot purchase, it's enabling us to get people closer to home. So at the moment, you've got a choice of going into just 3 or 4 care home provisions, but actually what it does by doing a spot purchase enables us to open up the whole of the care market in Somerset so that people can go to Frome if that's where they're from, or can go to Wellington
So it enables us to give people more choice because we're only going to be moving people once rather than twice or 3 times. So ultimately for us, it's about enabling people to be closer to home. We can talk about the block commissioning of beds, which we do as a local authority. So we have beds all across the county, which we commission, and we can obviously use those for hospital discharge as well. So we've done all the bed modelling in relation to discharges from the acute, and it's kind of identifying around we'll need 8 placements per week. So we've got capacity within the market to fulfil that. And just to remind people, the care home market in Somerset is really good. We've got 88% of our provisions are good or outstanding. So we have a really good quality of care here in Somerset and something to be really proud of. But ultimately it fits in with that picture of moving people just once. Really good. Thank you.
Thank you. Can I also just say as well, I forgot to say at the meeting, every person will have a written answer to their questions, all the members of the public. So please don't, you'll have it individually, okay? So I forgot to mention at the beginning of the meeting, apologies.
Thank you, Chair. And just to reiterate about the success and failure, just to reiterate, we do have a range of measures and we will be providing briefings to this committee. So again, you'll have some oversight of that. And the QEIAs, absolutely, we are doing QEIA for every community hospital site. And again, that can be shared with the committee. I will hand over to Andy. Do you want to come back on the buildings and then over to?
Gosh, a rebuild at Crookham would be lovely. New shiny hospital, but I think it's really unlikely, to be honest. And there are other priorities in the county as well. Some of our acute hospital estate is really tricky. But it's just to clarify, when I said earlier, it's increasingly difficult to care for frail older people. It's not impossible. Where we are struggling, where we've had to restrict access for admission now, is around patients who are bariatric, so large, have a very high body mass index, or are so frail that they can't get out of bed. So patients who are not ambulant, basically, we can no longer admit to those hospitals. That's not to say I don't want to overstate that. It's not that they can't be used at all. We've recently put a new roof on Crookham. I think we need to put a new boiler in next year. So we want to keep it. We want to invest in it. We think it's a really important site. It may not be ideal, but it's got quite a lot going for it.
Oh, thank you very much. Sorry, Dr. Davis, sorry.
Councillor Osborne. I'm very happy to come to another scrutiny committee and talk about assisted dying. I think it's a societal elephant in the room, and it's not part of this. I don't think. Just a quick note on the hospice movement. People see hospices, they see St Margaret's, they see Dorothy House, they see Western Hospice Care, and our colleagues down in Hospice Care in Devon. Hospice is always and has been about looking after people where they feel safe and where they want to be, and that's the absolute joy of working in Somerset. Somerset's got a really innovative model around palliative care. That's why all of those comments earlier about why community hospitals, bedded care away from home when it's needed in end-of-life care are really, really important. So St Margaret's is a good example of people who have moved care out into the community. Only yesterday was I down in Yeovil, not my normal patch, seeing someone with motor neuron disease, helping support their family, thinking about what they need, how we can help them over the next few weeks. So we are a group of people who provide end-of-life care as consultants through St Margaret's Hospice. That movement is the Dame Cicely Saunders kind of decreed bit. And even though Dame Cicely Saunders is not with us, I'm sure she would come back and kind of strike us down if we weren't doing it properly. She was that type of lady. So the hospice movement, how we look after people who are dying, it's always been important to us in Somerset, because how we look after our most vulnerable people is a real marker of who we are as a society. And there are a number of people who've been attributed to that quote. And it was the very first line of the strategy that I presented here, not here, in Somerset in 2014 when we started on this journey. So thank you. I'm very happy to come back and think about assisted dying with some of that early engagement stuff. When that law comes in, how it's enacted locally, I think is going to be something that this committee might be interested in. So it's an open for that when the time comes.
Thank you very much. Is anyone else before I go? Okay, I'll tell you, you're very keen, Alison. You're in there, which is good. I'm going to now go to there's 2 people online. If everyone's happy that, I beg your pardon. Councillor, you need to sit further in next time, because I keep missing you. Councillor. No. Sorry, I apologise.
Thank you, Chair. My comment is around patient transport and bus services. I know the lady in blue who spoke on behalf of Burnham Hospital mentioned the poor transport. And Dr. Davies did say something about bus services earlier. Many of us represent rural divisions. I don't want to pay my divisions more deprived of bus services than yours, but it includes Priddy. It did have a bus 3 days a week when I was about 10. And it had a weekly bus service for about 3 hours to about 4 years ago. Many of our areas, I'm looking at Councillor Sully, and I'm not too sure what's something I know Councillor Osborne represents Rural Division. I believe Councillor Trimnell does as well. We don't have buses, so I appreciate you guys are clinicians. How can we make sure that we have decent patient transport and a suitable number of volunteers to ferry people around? I'll use the case in point. My dad's now in care. It's great. He moved from Portland Hospital to Glastonbury. He's in the care home. It's brilliant. My mum's now got a dementia diagnosis. She's at home and Priddy. She relies on us ferrying around as and when we can. She's got a dental appointment on Friday. I've got to take her to. I've got to take some out of work. Luckily, I'm self-employed. So my main question is, how do we make sure if we are doing more home-based care, how do we get people to and from that care with the bus service? And there are no easy solutions to this. Some places just don't fit having a bus, even if it's a dial ride. How do we make sure there's a transport there for people who aren't lucky enough to have family like my mum has to get them there?
This might be on the next October meeting, we're talking about transport. It might be something that we actually bring back in, because the two things do meet together. You know, if we're gonna have people in local hospitals, there's still going to be transport needed, but it might be something we could bring back to the next one. Would you be happy?
I'm happy to do that. I mainly mentioned it because it was mentioned by a member of the public, and Dr. Davies did mention it. Yeah. Okay, thank you.
No, it's a very, very good point. You can't have one without the other, so that's excellent. I'm now going to go on to the two members of the public, two members online who've had difficulty listening, so the sound, and then I'm going to do the summing up, okay? Because I think we've really given this a really good airing today. Can I first go to Councillor Bruce, please?
Thank you, Chair. Yeah, it's been extremely difficult to follow this due to the sound issues. Thankfully, it's come back now, but apologies if I've missed anything in the debate because something may have been responded. I can see that a lot of the other members of the committee have pulled up on the point, which was my main point about what success looks like. And I'm going to start off rather with something else on the steering groups. So there was mention in the report that we were given about the steering group that was set up for Shepton Mallet. In terms of the members of that steering group, there was a mention that there was people on there for Somerset Council, but I'm not sure whether that was officer representation or member representation or portfolio holder. So I'd like some clarification on who was representing Somerset Council in that steering group. I'd also like to know whether the same steering groups will be set up for each of the community hospitals that are going to be affected, and how I think it was mentioned that anybody who wanted to be part of that steering group could put their name forward. So I'd like more information, more clarity on when people will be informed that a steering group is going to be formed and how that they can put the name forward for it. Whether we're going to have representation for members of Somerset Council there as well as town council members. And then really going back to the issue in terms of what success looks like. I think I'd like to put a proposal forward, if possible, Chair, that we actually do members of this committee receive a written report within perhaps a month, if that's a reasonable time frame. Otherwise, maybe we can look to the NHS to find what a timeline might be that might be reasonable, but a written report that gives those metrics and data so that we know at the moment what is being looked at for the criteria, and also includes some timelines, because there are various different hospitals involved. So I'd like to know what the timelines are expected to be. That initial report, then I think we should get a follow-up report within 3 months from the initial report, and then perhaps coming back to the committee again in 6 months' time. I don't think we need them to come back to the committee more frequently than every 6 months, but a written update report every quarter to the committee, I think would be useful. Obviously, that's just a suggestion open to other people to sort of, develop that idea. But I think we need to have something in writing to be able to see what the criteria is really, because that seems to be the nux of it. We need to know what success looks like and what the timeline is going to be so that we know at what point will it be decided, do we need to reverse these decisions or not? Because if they are reversible, we need to be in on that and monitoring it quite closely. Thank you.
Thank you, Councillor Bruce. You've read my notes, I think. I don't know whether you could see them, but that's why I was writing some notes down to say the very similar thing. It is important that we keep up. But I'm going to go to the next speaker, who is another portfolio holder for health, and that's the last speaker. This will be Councillor Graham Oakes.
Thank you very much, Chair. I'd like to echo Councillor Bruce's points. I entirely agree with everything she said. It has been incredibly difficult to follow this meeting because for a long period it sounded like you were using tin cans with string to talk to each other. And Jamie suggested we use the captions. I'm really hoping that they're kept because there are some very funny versions have come up, which might be entertaining later for the Democratic staff to enjoy about some of the things that were said. And I apologise for not being there. My excuse today is we're having a lightning conductor repaired. And that's the first time I've ever used that as the excuse for not being in a meeting. The 10-year health plan itself is a good plan. People should not be concerned about the plan. It's a good plan. It's such a good plan that some of us were talking about it 10 years ago. It's exactly where we should go. But I am worried. And I'm worried because of the way it's being implemented. And one of my concerns is that although there's money for it, the money is coming rather than been spent already. We should be modernising the way our community hospitals work because they're key to the success of health services in the county. With our A&E departments often struggling, ambulances being tied down, etc., we need to expand the number of minor injury units, and community hospitals are logical centres for this. I would just lobby for Yeovil, where we miss out on that area of the system because we have an acute hospital. The community hospital are complementary to the 3 acute hospitals, and we need to expand the services provided in them. It makes sense. Consultants moving to patients, not the other way round. Not just because of public transport, but also, as lead member for the environment, it's far better if one person drives somewhere than 30 or 40 people drive the same distance. Not to mention the small matter that getting into Taunton is a nightmare, and Yeovil and Bath are much better. Community hospitals are ideal neighbourhood health centres, though we do need to, and I hope people have noticed, we need to aim for a higher standard than a 6-day-a-week operation. It has to be 7 days a week. I'm not sure why that days dropped in there. In 1.3, the report states that these centres will bring rehabilitation into the community. Yeah, it's excellent, but best achieved by expanding the service, not by just redistributing it. Rather than reducing the number of rehabilitation beds in the existing community hospitals, the focus should be on improving their service to speed up rehabilitation, at least until after the alternative community services are fully up to speed. And can I just give a little bit of advice to the Trust? There were 2 different sets of data came out about how long the average community rehab time is. Quite dramatically different, both available online. A clarity on what the real figures are and why Somerset is below the national average, or on the national average, depending on which data we're using. That's a little bit annoying. The plan relies upon community rehab teams taking on much bigger workloads and care homes increasing their rehabilitation function. Again, I don't have any concerns with that. I think those are good things to do. But there may be some view that the rehab teams at the moment across the county are performing at a high standard. They're not. They're not fully staffed in some locations. That is a problem. And care homes will have to modify the way they work to take on a far greater rehab approach. A brilliant idea. But this is an idea that we should have been talking about a year ago if you want to start closing beds today. The plan has been activated before there's evidence that the community rehab teams are ready for the greater pressure, including far greater support for care homes, which Traditionally, in the past, care homes have been given a low priority by community rehab teams based on the theory that that resident is safe compared to people in their own homes. Later in the report of 311, it refers to Somerset Council investing 1.6 million over the next 12 months to provide reablement at home. I'm really proud of this. I think this is really good. But closing the beds before the money is spent, before those specialist staff have been recruited, is a brave decision. It's also worth pointing out, and I know it was earlier, that 3 care homes are losing their funded pathway beds, and the point was made that it's silly to move people. You can take one move out, especially for people who've already been moved 3 or 4 times around acute hospitals. That happens. So I can understand that logic, but again, we seem to be lifting the support before we've got the new service fully in place. Community services, it's not clear if this means the new community health centres or outside them are also going to be providing children's services and dementia services. I'm particularly interested to know what development of these new dementia services would be, because the NHS generally is pretty damn poor at dementia care. And if it's going to be improved, I personally would be very interested. At 1.7 of the report refers to test and learns. I love that expression. It kind of says, yes, we're going to try something, might work, might not. Let's see what happens. It's good to learn from your mistakes. I think we need to learn that consultation should happen before, not after an event. And we should also learn that planning it so that as a highest chance of success with the lowest risk should be the way forward. This plan does not do that. It doesn't do that at all. It also refers to temporary bed closures. And the point I think someone made quite clearly was if you've put all that brilliant diagnostic gear into a bay where the beds were, we're not going to let you take the brilliant diagnostic gear away, even if you need to bring the beds back. So it's going to be a problem. And I think there's been a little bit of shortcutting going on there. Contracts are being changed today. Staff are worried today about whether they have a job. And I was disappointed. I know they're being offered redeployment, but if you're working in Glastonbury, do you want to go to Taunton, really? That I was told directly by a member of staff that she was fearing she was going to lose her job. So there is some breakdown between the senior management and their staff that they have a level of fear that apparently they don't need to have. Because I'm sure that what we've been told is spot on. But this change does not feel like temporary. It doesn't really feel like this test and learn approach. It feels like it's the beginning of a strategy that's a good one, but it's one that I'm not convinced is phased correctly, is the management term, I think. And my final point, and if it was been answered, I apologise, but it was a nightmare trying to listen. What's going to happen about winter pressures? Because talking to colleagues who work at more than one community hospital, they've said that around October, winter pressures start to put a pressure on the community hospitals as they support the acute hospitals. We're having a long, hot summer. What happens if we have a really cold winter and we have a lot of flu and whatever else is kicking around and we've reduced the number of beds? And that's where I'm going to leave it. Thank you.
Thank you very much. Very, very pertinent questions, as always. And thank you for them. And I hope that we can get somebody to respond to them now, please. I'm over to, who's going to take this one first, please?
I'll take the winter issue, if that's okay, Chair. It seems counterintuitive, doesn't it? Closed beds deal better with winter, but in truth, the average length of stay in our community hospitals is over a month, perhaps 40 days. So the numbers of discharges that we can get to community hospitals is quite limited over the course of a winter, whereas the flexible new services that we're investing in that help people to get home, and bearing in mind we think some of the people who've gone to hospitals previously would be better off could go home. Those services can be much more flexible and responsive. So overall, we would see this shift in model as having a positive impact on hospital flow and coping with winter, although heaven knows that's always a massive challenge.
Certainly is. The other questions, the other points that Councillor Oakes raised? I think the point about contracts being changed today, I think on staff, there's definitely a different message gone out there. I think that does need to be addressed. I think if you've got staff worrying about jobs and worrying about which you've said that is an issue, there clearly is something going on. And I think we do need to support our staff and make sure our staff are okay, because they do not want to go from one area of Somerset to the other. I get that, absolutely understand that. They've dedicated their lives to the job they do, and like everyone does, and particularly for nursing staff. So could you answer that, please?
And I said that earlier on, so we're in the very early days, so it's difficult to give prescriptions. So we're only just been talking to staff yesterday and the day before. So we're in the 2-week period now of time about where those that were unsuccessful in the jobs where, you know, in the basis where they will actually go. So those conversations are taking place now. So I can't answer that definitively about where people are going. But there have been some great, you know, even conversations I had yesterday with some of the ward leaders. There have been some great opportunities that some of those colleagues have been able to do. So West Mendip colleagues, I think I said this earlier, have been able to, there's 2 of them will be trialling out the RUTC, for instance, and there are some other opportunities that are on locally within that area of West Mendip. But we can't be definitive, because what happens is that people through the process of redeployment go through a trial period, and that works for both colleague and the service in which they have gone to work out whether it's the best fit for them or not. And that's going to take us the next 3 or 4 weeks yet before we're clear as to what that looks like. So it's probably something we need to come back to you with the definitive detail.
The thing that's important is this is a trial.
Absolutely.
So if it doesn't work, then we need to make sure that staff will be able to go back to what they were where they originally. No doubt there will be another trial, but what I'm saying is we need to protect our staff at all times. That's really important. Councillor Oakes also mentioned about the 7-day working operation. I think we'd like to, if you take that back, please. I think like everything today works 7 days, and everybody says when it gets to Friday, you mustn't get ill on a Saturday because you've got no chance in hell of getting seen to. Well, we don't want it to be like that. We live in this day and age today where people can work different shift patterns. So I think that's a very, very good point, and I hope you can take that back for us. You know, anything you wish to add to any of the no.
Just to say that was in response, the 6 days was in response to the National Neighbourhood Health Centres. I'm speaking on behalf of my foundation trust colleagues here, but a lot of the community services are delivered 7 days a week.
Yeah, I mean, I've noticed that lots of X-rays and things are done on Saturdays now in our community hospitals, which is a great thing. Before I sum up and give my final wording on this, I'd like to go to the portfolio holder, who just might want to say a few words, please.
I mean, I just wanted to say a little bit. For example, I know from my colleagues that on a daily basis there are empty beds in community hospitals, quite a few actually, because just taking someone out of hospital and sticking them in a community hospital is not the thing to do. There's got to be a reason for them going there. So they're doing a convalescence or something, and they've got some service and support. And obviously we've got some excellent stroke care community hospitals, which are absolutely vital. I just want to say, I hope the people in the room felt this has been useful. It's really, thank you so much for coming and listening and taking part and asking questions. I'm really, really pleased to see that. And we haven't got all the answers. I certainly haven't got all the answers. One of the things that we are concerned about at Somerset Council is that if we do have people coming back into the community and into our care homes or into their own homes, it will mean extra costs for adult social care. Now, we are sending less people to care homes and keeping more people at home, and that means more domiciliary care, less care home fees. Now, for us, care home fees are usually more than looking after somebody at home. But if we're getting more people coming out of hospital, which would be great, that's what we all want, we are going to need some money from somewhere, probably from the government, in order to pick this up, because we don't have extra money to spend on adult social care than we're already spending. It's a huge budget, as everybody in this room already knows. And you can't, and what the NHS are doing and being tasked by the government is to plan things for the future. I'm delighted. It's like turning around the Titanic, or as we always say, it's like trying to mend the engines when the plane's still in flight. It's really difficult to do. But we want that to happen. And they've been told to save money as well, but that can't be at the expense of Somerset Council. We are going to be really in trouble if we end up spending a lot more money on our adult social care than we've budgeted for. And we've done a really careful budget, and we're saving money where we can, and we're doing things better and all the rest of it. But I am concerned, but I just wanted to highlight that.
Thank you very much. The thing is, we're all living longer. I'm going to bore my committee to death here. I broke my leg in October. I'm sat here today with a broken leg. It's still broken. It's not mended. But they sent me out with a stick, and I have to say it's probably been the best thing. But I don't know when I'm ever going to mend. But you know, it is difficult today. And I think, but what I would like to say is that I think the members of the public tore off the plaster in a way. Forgive me for saying that, NHS people, but they did. They tore off the plaster to let us see the greys, the possibility of a greys. And I think that's been very, very worthwhile. And I want to thank you all very, very much for coming, because all of your questions were very, very pertinent. And what they'll do for us is they will keep us looking. We can't change it. We've not got the power to change it. But what we've got the power to do is work for you, continually work for you to make sure that you get the NHS what you want. It's vitally important that you are happy. And if this trial doesn't work, I can assure you, you will be back here, and we will find a way, because that's what we've got to do. So what I would like to say is that we do need a written report, the data, the metrics, the timelines. We need all that, definitely within a month, I would say, if you can give us something. I would actually ask you, we'd like you to come back within 6 months to us here. And as many members of the public can come again and ask many questions if you want. If you feel that you've got some reasoning for things not working, if you've got reasoning like Councillor Govia that it did work, we want to hear. We want to hear, because this is a scrutiny, but it's also your scrutiny. It belongs to the people, and your voices must be heard today. So we really, really appreciate it. So I'd like to thank my colleagues from the NHS who've come today, who've scrutinised. They've been put on the big light, but I do appreciate it, and you will come back. And as I said, Dr. Davies, you're not going anywhere, because I'm obviously going to need you. So I would like to thank you very, very much for coming today. Thank you all, and I do hope that you found this beneficial today, as we have. So thank you very much. I declare the meeting closed. Thank you.
Yeah.